Shilpa, we can start.
So can you just play the video, sir?
Okay. Good morning and warm welcome to online anesthesia and anesthesia update in Zoom platform. Sponsored by Acrola and hosted by A1 Logics, and our media partner is Anesthesia TV. Today we are addressing pediatric anesthesia update. Many of our viewers have inquired why you have selected two different unconnected topics today. So the emergence delirium is an important issue to be addressed since the incidence of ED is from 20 to 80%. And most of the literature say it is around 20% in all pediatric anesthesia cases. So today we have Nandini madam as a renowned pediatric anesthetist from Mumbai to discuss on this subject. And second topic is regional anesthesia in pediatrics. So you know, all of you know the regional anesthesia is more popular in adult population, but not in pediatrics. Why is it so? Is it difficult to practice? We have a lot of questions in our mind about it. To discuss about it in details, we have internationally renowned pediatric anesthetist, Dr. VRUSHALI PONDE with us. So today's session will be coordinated by Dr. Sarva Vinothini madam. She will introduce the speakers. Over to you, madam.
Good morning, sir. Morning, everyone. It's nice to have you all here on a Sunday morning. I take privilege in welcoming Dr. Nandini Malay ma'am. She's a senior consultant and head in SRCC Children's Hospital, Mumbai. And she's an ex-professor and head of the Department of Anaesthesiology of KEM, Mumbai. And she's the current vice president of National IAPA. And she's a faculty for IAPA Paediatric Anaesthesia Fellowship also. She's also an AHA certified instructor for PALS, PPLS and all. And she has more than 100 publications, of which 22 are original research papers. And she's a joint editor of many chapters and books in various books, and she also has got so many fellowships to her credit. And her topic today is emergence delirium. All that begins well should end well, but we should always have we should always begin with the end in mind. So the end can be catastrophic if it is going to be an emergence delirium that is unmanageable at sometimes. That can be damaging to the child, to the attenders and to the healthcare people also. So ma'am will now enlighten us upon emergence delirium. Over to you, ma'am.
Thank you. Thank you, Vinothini, for that nice introduction. Shall I share screen?
Yes, ma'am.
Is my screen visible?
Yes, ma'am.
Yes, ma'am, visible, ma'am.
Okay. So thank you. Good morning to all of you and happy Sunday. Thanks for the lovely introduction, and thank you to Dr. Edward Johnson and the entire team at Online Anesthesia for this invitation to meet with you and have a discussion. It's truly a privilege. I was talking about how online anesthesia started during the pandemic, and I think the pandemic has taught us so many lessons of how to cope and how to manage, and a new way of learning. And it is pretty impressive how you all have managed, I think, 52 sessions in the last year and now once a month. So congratulations on that. I'm going to be talking here about emergence delirium after pediatric anesthesia, a very common problem. And let's see what's new in how to avoid it and how to manage it. I bring greetings from SRCC Children's Hospital. We are a 200-bedded tertiary children's care facility in South Mumbai, managed by Narayana Health. So we cover the entire spectrum of children's problems, and from point of view of surgery, we have the entire spectrum of surgery, beginning from general pediatric surgery to orthopedics, to complex super specialty surgery, including cardiac, neuro, and also fetal interventions and transplants. So practically everything for children under one roof. That's where I come from. And we have the 1-year IAPA fellowship, as Vinothini said. And we also have permission for the 2-year FNB, which is started this year. They've announced it this year, and we have permission for 2 candidates for the FNB course run by the DNB board. So anybody who's interested is most welcome to train at my institute. So before I begin, and I believe there are a lot of PGs here also, let us begin with a small quiz question. And hopefully at the end of my talk, we will be very clear about what the answers would be. So which of the following statements is true about emergence delirium in children? The incidence is least in children 1 to 5 years of age. The threshold PED score, which is the Paediatric Anaesthesia Emergence Delirium score to diagnose ED, is more than 10. The incidence is less with sevoflurane compared to desflurane. The incidence after inhalational anesthesia is less than 1%. So I leave you to think about the correct answer, and meanwhile, we'll move on. So let us look at a typical case, just another ordinary day for me and Vrushali and a lot of us. We have a 3-year-old for circumcision. Now, these are typically daycare surgeries. Child will come in the morning, there will be no IV line, and we don't like to poke babies like that. So typically, we would have given some pre-medication. This child was very playful. He came with us into the OR, didn't miss his parents at all. So we held the sevoflurane mask. We continued, we took the IV under sevoflurane anesthesia, and we continued the anesthetic with sevoflurane and LMA. For analgesia, we gave the penile block. Everything went all right. 30 minutes, surgery was over. Patient is outside in the recovery room. And in the recovery, the child wakes up crying inconsolably. He's thrashing about, he's disoriented, he's creating a scene. What should have been done and what do we do now is a question. So what's going on? So clearly the child is agitated postoperatively, and you're wondering what could have been the problem. Is it pain? Is it emergence delirium? Is it a temper tantrum? Because this is a typical 3-year-old prone to, throwing a tantrum when he doesn't get what he wants. Preschooler cannot really verbalize that well what he wants. So, it could be a temper tantrum you're thinking, or is it something else altogether? So this is the outline of my talk. In the next, say, 40 minutes or so, I'm not going to take the full hour because I'm quite cognizant that it's a Sunday and it's also family time for all of us. So what I'm going to do in the next 40-45 minutes is define what is emergence delirium, talk about the incidence, the risk factors, the causes of emergence delirium as we know it, how to prevent it, how to manage it, and some take-home points at the end. So emergence delirium is not a new thing. It has been described by Eckenhoff and colleagues as far way back as 1960s as a disturbance in the child's awareness or attention to his/her environment with disorientation and perceptual alterations, including hypersensitivity to stimuli and hyperactive motor behavior in the immediate post-anesthesia period. So typically you'll have a child who's just out of the anesthetic, who's in the post-operative area, and he's he's looking agitated, he may be thrashing around, he's inconsolable, whatever you do, he doesn't stop crying. Very interestingly, they don't make eye contact, they may not verbalize what they want, and they are essentially creating a scene there. Almost 60 years later, we still have questions about what exactly is emergence delirium, how do we prevent it, and how do we manage it? So it is a problem in pediatric anesthesia, especially so. A common synonym and a common terminology which is used interchangeably with emergence delirium is emergence agitation. But agitation more so refers to a physical, problem. Like, for example, the child, it may be more related to pain and anxiety than delirium itself, but more or less in all published literature, we can see these two terminologies which are often used for one or the other. So let's look at how big the problem is. Now, the incidence of ED, as Dr. Johnson mentioned, has been quoted with a very wide range, about 2% to 80% of all pediatric anesthetics. And the reason for this extremely wide range for incidence may be because there is a confounding factor of pain. So what are the tools which the researchers have used to measure ED may be quite varied, and also how often they have tackled pain and then they have said this is not pain, this is ED. So that's why we have a wide range. But by any yardstick, at least about 30%, 20 to 30% of incidence of ED is there in pediatric anesthesia. And typically the symptoms manifest on recovery of consciousness and last about 15 to 30 minutes. So if they last only 30 minutes, why do we worry so much about emergence delirium? What's the big deal? So of late, or since the last decade or so, there has been a lot of focus on how the family perceives the anesthetic, the whole experience. So clearly, parents of children who've experienced emergence delirium are quite distressed. It raises questions about the very quality of your anesthesia. So you may have done everything well, but at the end, if the child wakes up in this manner, it really raises doubts as to what you have done and whether you have done anything correctly. There is also a risk of self-injury because during that time, when the child is not completely in his senses, he may pull out lines, the IV lines may come out, Riles tube, dressings, everything. So there is a definite risk of self-injury. So additional personnel are required to just restrain the child, see that it doesn't pull out, vital lines and tubes. It may add to increased medical care costs because you would be giving some medication to take care of the agitation, and then that may delay discharge. Also, interestingly, and more of concern to us is also the long-term psychological problems. So it may not be limited to just those 15 minutes or 30 minutes. These children have been shown to have increasing, maladaptive behaviors, which may persist for as long as 1 or 2 weeks. So they may become, extremely clingy. They may have, new onset bedwetting, which was not there, and they may have, disturbed sleep patterns or eating patterns, which can all have, long-term psychological consequences. So definitely we have to worry about ED, and we have to do something to prevent or manage it. So can you predict ED? So because if we had the foresight that this child is going to develop ED, maybe we can do something about it before it actually manifests. So it turns out that some certain procedures, for example, head and neck surgeries and also ENT and ophthalmologic surgery have got the highest incidence of emergence delirium. And in general abdominal surgeries, it is urology which has got a higher preponderance. Now, in the anesthetic technique, volatile agents have got the highest incidence. All volatile agents can cause ED, but increasingly it is the agents with a faster wake up, like for example, sevoflurane or desflurane, which have got a higher incidence. Halothane doesn't seem to be associated with an increased incidence of ED. Pain definitely is a causative factor, but pain can also be a confounding factor. I say it is only a confounding factor because even in procedures where there is no pain, for example, you have an MRI procedure for which you have used sevoflurane, the patient can still have an emergence delirium. But yes, it is a definite confounding factor, and we must do everything to alleviate pain so that we can say, okay, this is not pain and this is probably emergence delirium. Patient rate plays a very, very important role. So it is a preschooler. The maximum peak is 2 to 5 years of age. Probably because they have never been separated from their parents and they are all often in the confines of their home. Psychological immaturity, preoperative anxiety in the patient and in the parents. So you can look at families and you can tell, if your parents are super anxious, usually the child is also anxious, and you can kind of predict that this is, going to be a problem for you in the postoperative period. The temperament of the child matters. So children who are emotionally labile, children who are very clingy, who are kind of antisocial, these patients have got a higher incidence of ED. Now, you must rule out certain physiologic conditions which can be confounders. For example, if a patient has got sepsis, he is hypoglycemic, if there is some electrolyte imbalance going on, hypoxia, hypercapnia, these can all be confounders. So before you say that this is emergence delirium, you must be very, very sure that you have ruled out other factors. A full bladder can sometimes cause problem in the perioperative period, postoperative period. A patient with raised ICP can behave in just the same manner as a patient who has ED would. So you must be very sure. I had a patient once who, or rather more than once, who some children just won't stop crying until you take the IV out. So how do you differentiate it with just a temper tantrum or an emergence delirium? So the difference is that these children usually are very coherent. They will point out to the IV line, they say they want it out, they are making eye contact, they're actually communicating to you and to the parents that this is a cause of anxiety or their agitation. So that's how you kind of can differentiate by ruling out all the other factors that this is nothing else but emergence delirium. So I cannot reiterate this more. Emergence delirium is a diagnosis of exclusion. So rule out pain, which is a commonest thing which will happen after surgery. Rule out other factors before you say that this is emergence delirium. So now what causes emergence delirium? So is it rapid emergence? Because we didn't see it in the days of ether or halothane. It could be a factor. Or is it emergence in the presence of surgical pain? So this again, there is a conflict here, because you can have a patient who's undergone MRI, clearly no pain, and still has emergence. Or you could have a drug, say like, for example, you manage with propofol and you still have emergence. So propofol has, so for example, propofol also has a rapid emergence, but the incidence of ED is less. So what I mean to say is probably not only rapid emergence, it is not the presence of surgical pain which causes ED. Clearly, it is multifactorial. Probably what we are trying to thinking to believe is it is anesthetic agents which are acting on the immature nervous system. And I say so because the incidence of ED is so high in the pediatric population, whereas in adults or even in the in the older geriatric populations, the incidence is about 5%. It could be preoperative demeanor and anxiety, which is definite role. On top of that, you have anesthetic agents which are acting on the immature nervous system. So this is probably what we think is causing ED now. How do you measure it? So it's important that you measure, because then you would have robust objective evidence to say it is pediatric emergence delirium and nothing else. So this is a standard PED score. It's an acronym for Pediatric Anesthesia Emergence Delirium. It's a 5-point score. It is a validated score, and it has these 5 elements which are rated from 4 to 0. And it has got both elements of cognition and agitation. So the only limitation of this score is that, again, some elements are subjective, and also it is quite time consuming. So if you have a child who's thrashing about in the ER, the last thing you want to do is, have somebody, have it measured here and then think about doing what to, do to manage it. So an easier scale is a Cravero scale, again a 5-point scale, but simpler to measure, and a score of more than 4 is suggestive of ED. Other scale which is validated is a Vacha scale, a simple scale, again rated from 0 to 4. And so what is now believed is that you could, if your child is behaving, a little agitated in the post-op, what you could do is use the Vacha scale quickly, and then you could measure it more objectively with the PED scale. So this is how you could, optimize the use of scales so that you can actually have a measurable a number and say it is pediatric emergence delirium and nothing else. So how about prevention? Because prevention is definitely better than treating it. So let's look at what is there in the literature and what do all the reviews and the meta-analysis say about preventing ED. So these are a whole list of strategies, and this is a lovely article by Kira Mason in BJA to how you can decrease the incidence of emergence delirium in children. So top of the list is behavioral management, what volatile anesthetic you choose, your choice of anesthetic technique, and a whole list of medications which I will go into in detail, acupuncture, regional anesthesia, and pain control. So I disagree with what Dr. Johnson had said in the beginning, why we have 2 diverse topics today, regional anesthesia and emergence delirium. But turns out that there is a role of regional anesthesia in also preventing and managing, preventing emergence delirium. So let's look at each drug one by one. Midazolam. Now here the reports are extremely conflicting. So there are studies to show that oral midazolam pre-medication does not prevent ED. Now, midazolam is one of the commonest pre-medication agents which across the board all anesthetists use, whether they're doing only pediatric anesthesia or they're occasional pediatric anesthetists. It's a commonly available agent. It has got, a shorter half-life. You can give it by the oral route. So it's very commonly used. But turns out it doesn't prevent ED, probably because the half-life, it peaks at about 50 minutes or so by the oral route. And by the time the anesthetic has ended, probably the sedative action does not, persist into the post-operative period. That is why. And also midazolam has got, at least 30% of children will have a paradoxical reaction. So it's not quite predictable. You give it to cause anxiolysis, but at the same time, the children may not become, anxiety-free, and they may actually have a paradoxical reaction. So that's why, it's not a great agent for prevention. But there are also studies to show that a small dose of IV midazolam has reduced ED in strabismus surgery. So again, should we stop using midazolam? What is the this? The verdict is that because it's commonly used and because it has got some benefits in preventing anxiety, and it's a very easily available pre-medicate, we can continue to use it. But at the same time, it doesn't guarantee you that it will prevent emergence delirium. It might cause anxiolysis in a large population. How about fentanyl? Now, again, a single IV dose at induction has reduced ED in short surgical procedures, and this could be because of its analgesic effect for sure. Remifentanil, we don't have it yet, but when you have a combination of remifentanil and propofol infusion, that also has been studied, and there is a marked reduction in ED. So opioids, by and large, seem to reduce ED, and this could be predominantly because of their analgesic effect. What about propofol? Now, this is one drug which wins hands down, but it all depends upon the timing of administration. So if you have used propofol for induction only, there is no reduction in ED, probably because of the short half-life. But if you have used propofol as an infusion throughout the anesthetic, or if you have used volatile anesthetic, but at the end you have given a dose of propofol, a small dose of propofol at the end of the surgery, there is a definite reduction in ED. So it all depends on how you use propofol. What about ketamine? Here there is a dichotomy. It seems to work. There are so many reports which are saying that propofol works. You could give it intranasal, you could give it orally as a pre-medicant, you could give a single small dose at the end of surgery, and it seems to work. But the concerns are it may prolong recovery and it may increase post-operative nausea vomiting. To me, I wouldn't use ketamine as my first drug because ketamine itself can cause kind of a reaction where it would, it could itself cause a reaction which is similar to emergence agitation, but there are reports showing it does work. So I wouldn't use it, but this is what the reports are saying. What about clonidine and dexmedetomidine? So this is one class of drugs which reduces ED regardless of route and time of administration. So this should be there are systematic reviews, there are meta-analysis which show the beneficial effects of alpha agonists on post-operative behavior in children. So this is one class of drugs which win hands down. So let's look at how you can give it, when you can do it, and how it works. So nasal dexmed intranasal in doses as small as 1, and some groups have used even 2 microgram per kg has reduced ED. There are other benefits too. It reduces, they're also analgesic, it reduces PONV, it reduces shivering. So there are a lot of, host of other benefits for alpha-2 agonists. There are groups which have used dexmed as a bolus, continued with an infusion, and it has been found superior to fentanyl in reducing ED. Or if you haven't used either of it, you haven't used it as an infusion throughout, but you can just give a small dose of dexmed just prior to extubation, and it is superior to propofol. What about magnesium sulfate? This has been hailed as a super adjuvant, and we use it of late for a host of reasons, and it is also being used for preventing ED. So this is again adenotonsillectomy, where they've used a 30 milligram per kg bolus followed by 10 milligram per kg per hour, and it has reduced ED by 50% following adenotonsillectomy. And mind you, many of the studies of ED in children has been in adenotonsillectomies because typically this is a surgery where there is a high incidence of emergence delirium. There has been some debate as to whether this has been because of the effect of magnesium in reducing post-operative pain. Nevertheless, there are reports that it seems to work. Pain control will regional blocks. Definitely reduces ED, probably because again, you are removing the confounding factor of pain. And also if you've added clonidine or dexmedetomidine to your blocks, then we know that alpha-2 agonists by whichever route will reduce ED. So probably that's the reason why regional blocks clearly win for reducing ED. Gabapentin, prior to surgery, oral dose reduces ED. And this is mostly used by us for major surgeries, older patients, say, for example, major spine surgery. This is where we would use typically gabapentin. I don't use it that often for emergence delirium. We've been using it mostly for chronic pain post-operatively. Melatonin, again, only an anxiol. It's actually just a sleep-inducing medicine, but oral melatonin also seems to work in reducing ED. I don't have any personal experience though. What about non-pharmacologic interventions? They seem to work. So acupuncture. Now this electrical stimulation of what is known as a heart 7 acupuncture site, and because I have no personal experience, I had to go up and see what it is. It's a site at the wrist, and it has been proven to reduce emergence agitation in children. Again, behavioral distraction techniques to reduce anxiety clearly work. So, there are papers, there are several, I just highlighted a couple. Video distraction. So basically, whatever you can do to reduce anxiety in the preoperative period seems to reduce delirium in the postoperative period. So if it is video distraction, which works for the kid, if it is parental presence for the management of preoperative anxiety, there are places where they would take the parents into the preoperative, to the operating room and induce the child in the presence of the parents. This can be a little bit, problematic if the parents themselves are anxious. So you really need to know the family and see if the parents are anxious, that it can actually translate to more anxiety during the induction. So, but if they are cooperative, they're okay, then it seems to work for reducing ED. Simple things like transport in a toy car. This seems to work for us. So if the child is okay, you put him in that car and you get him into the OR, basically do whatever you can do to reduce preoperative anxiety, and it seems to work for postoperative ED. Now, this is a from the Cochrane database, which looks at relative risk reduction for emergence delirium. And this is from what agent works best to least. For example, propofol as a single agent is best for ED. That means propofol for induction, continue the propofol as TIVA, and that's your relative risk is least for emergence delirium. Halothane as a single agent, but I'll not go too much into it because most of us are not using halothane. Propofol to maintain anesthesia after sevoflurane induction is inferior to propofol TIVA. So if you really want to reduce ED risk, use propofol and stay away from sevoflurane altogether. What about adjunct agents? So top of the list is dexmedetomidine and fentanyl. Fentanyl here again, probably because we're taking care of pain. Clonidine also is a good agent. So basically alpha-2 agonists and fentanyl are your go-to. And lower on the list is again here, propofol is lower only because it depends upon the timing. So either use propofol TIVA or use propofol at the end just before extubation, and then you can reduce your relative risk. What is clearly ineffective is oral midazolam pre-medication and parental presence at emergence. So if you think that if a child is inconsolable and is thrashing about, maybe getting the parents in will console him, that's not going to work. So what we do is, because ED is so unpredictable, we do whatever we can to prevent it. But at the same time, there's no saying that, with 100% guarantee that your child is not going to wake up, calm. So what we do is we ensure that, the first 10 minutes when the child is in the recovery, we don't get the parents in. Only when we are sure that the child is, not going to wake up in a kind of a delirious state, do we get the parents. Because once they come in and they see this kind of emergence, it can be pretty disastrous, parents getting agitated. And it's not only that child and the parent, the neighboring child and the neighboring family also gets agitated. And overall, it's a very unpleasant scene in your recovery area. So what are the non-pharmacological strategies? And I keep saying this again because this is, it's extremely important to use non-pharmacological strategies as well, because then you use less of your pharmacological strategies, which may eventually delay discharge. So if you have the time and you have the resources, you can, work well in advance. So this is an advanced program which is mentioned in the books, and I put it here as an acronym, but we can definitely use elements of these. You need a lot of people to, kind of have a program running, the psychologists, the child specialists, but even otherwise, you can try, basically it's an acronym for anxiety reduction, distraction, which we can very easily do, video modeling, adding parents provided they are calm. It's no point adding anxious parents to an anxious child and having trouble for you. No excessive reassurance is extremely important. I always tell my PGs, 2-3 people talking and telling the child that nothing is going to happen. The child is thinking something is definitely going to happen. So no excessive reassurance. Tell them exactly. It depends upon the age of the child, what you're going to tell them, in what language you're going to tell them, and in what manner you're going to kind of reassure them. But tell things like they expect to happen. Coaching, which means essentially training the parents and the family if they are kind of in a receptive sort of situation well in advance, and exposure. So basically this is the advanced acronym, but essentially preemptive education also helps. So if the parents know, if the child knows what he's going to expect, some short videos if you have ready to kind of go lead them through the whole process with the pre-op, the intra-op and the post-operative period, it might help to reduce anxiety and thereby reduce emergence delirium. So essentially reducing parental and child pre-operative anxiety works. How will you manage it? So non-pharmacological measures is mainly ensuring patient safety and then reassuring the parent that this is self-limiting and it is not going to last more than 15 minutes, and we are going to give pharmacological rescue therapy which will terminate it right away. So what has been listed as rescue is IV midazolam, interestingly, propofol, fentanyl, and dexmedetomidine. These are all small doses, mind you. You can look at the doses. For me, my go-to would be either propofol or fentanyl, simply because I'm not very sure whether midazolam is going to work, because we know there is a paradoxical reaction in a significant percentage of patients. If I have any doubt as to whether it is pain, I would give fentanyl as my first drug. If I'm very sure that the child is not having pain because my regional has worked intraoperatively and there is no reason why he should have pain suddenly postoperatively, then I would give propofol as my go-to drug for rescue. Dexmedetomidine is a great agent, but the only reason I don't put dexmed on top of my list is that you have to prepare it, you have to, it's a bit expensive, and then you have to give only 0.3, mics per kg. This should not be 8 milligram. So, opening an ampule, a costly ampule, and making it just for that is a reason why I wouldn't put dexmed on top. But we have, when you have, say, given a dexmed infusion intraoperatively or had dexmed ready for some reason, you could also give dexmed. For our cleft palate surgeries, very typically, again, high risk of emergence delirium, what we do is we continue dexmed infusion throughout surgery. We even take the dexmed infusion pump post-operatively and continue it if we feel that the child is waking up, in a delirious state. So that's rescue for you. Now, this is everything put in a nutshell, how we can prevent emergence delirium. So first of all, you identify patients at risk of ED. So if your child is a preschooler, falling in that 2 to 5 years age group, if there is a history of anxiety or a history of ED in the previous surgeries, or the procedure is ENT or ophthalmology, then I would think, okay, this is ringing a bell. This is a child with a high risk of emergence delirium. So then you plan an anesthetic to reduce the risk of emergence delirium. Can you avoid rather sevoflurane altogether? If the answer is yes, then you plan for propofol-based total intravenous anesthesia. And you optimize strategies to reduce anxiety. So you've talked to the family, you use non-pharmacological measures, you use pharmacological measures, and you also optimize post-operative pain control using everything you have. You can use regional usage. If not, then you can use opioids, NSAIDs to optimum effect. For some reason, if you cannot avoid the use of sevoflurane, then what you would use is any one of the adjunct medications with the inhalation anesthetic to reduce the incidence. So you could use propofol at the end of the anesthetic. You could use dexmedetomidine infusion throughout the anesthetic, or use a small dose at the end. You could pre-medicate with clonidine. You could use fentanyl and other opioids. And you could even use ketamine, but I would still put it bottom of my list because I'm not very sure how it would work. If your child has waking up and he's agitated in the post-operative care unit, first of all, rule out hypoxemia, hypotension, because again, this could lead to a clouding of consciousness. Your patient is irritable, inconsolable, not making eye contact, not knowing what he's doing. Rule out upper airway obstruction because hypoxia again can cause something of a similar picture. Hypoglycemia, again, the child could be confused. Pain, either surgical or non-surgical. Once you've ruled out all these causes is when you make a diagnosis of ED. Again, we know non-purposeful agitation, kicking, absence of eye contact, and absence of awareness of surroundings. If you have the PED score at your disposal, you use it, you can measure it. So that helps. And then treat emergence delirium. Again, like I said, propofol, if you're sure it's not pain, if you have a doubt, fentanyl, and then midazolam, little bottom of the list. My go-to drugs, again, top two, propofol and fentanyl. So let me end with a case. Say you have a 6-year-old with a previous history of ED and he's scheduled for a tonsillectomy. So again, here, red flags. This is a 6-year-old. He has got a previous history of ED. He's scheduled for a surgery which has got a high risk for tonsillectomy, for ED. So how would you proceed with anesthesia? Could I have any of the PGs answer? Is it possible, Dr. Johnson?
PGs can post their answers in the chat box.
Oh, okay. Shall I wait for the answers in the chat? So 6-year-old, anxious parents, previous bad ED, and scheduled for a surgery which has got a very high incidence of emergence delirium.
Somebody said, madam, that the English reagent, I will use English reagents to work for me.
Okay. I would say that's asking for trouble, but okay. So does he mean that he will use it for induction?
Yes.
Praveen Kumar. So will you use it for induction? Or will you use it throughout the case? For induction. Okay. But the child is not coming in. Child is very anxious. Parents are super anxious. How are you going to get the child in? I'm presuming you're thinking, okay, we don't have an IV line in place because the child won't let you go near him.
Somebody posted in YouTube, that is, I would like to use dexmedetomidine.
Okay, how? How are you going to get the dexmed in? Is it pre-medication? Are you going to use it intraoperatively at the end of the case? How are you going to approach this child? This child is coming into you. He's not even coming into your preoperative area. He's running away from there.
He's posted I will go for a pre-op counseling as well.
Fantastic. Okay. Pre-op counseling. Pre-op counseling is kind of working because, last time also they had pre-op counseling and still had very bad ED. So there's a lack of trust here. Parents are super, super anxious. Only child. Clingy. Extremely pampered. Any other answers? How would you get the child to your preoperative area? How would you let him even accept are you planning, if you're planning inhalation induction, how is he going to accept the mask? And he's a 6-year-old, good weight, 25, 30 kg child. Are you going to pin him down and put that mask on? Any other answers? How are you going to get that mask on? Okay, you'll use sevoflurane.
Somebody posted as ketamine IM1.
Oh, intramuscular ketamine. So most of us pediatric anesthetists, we actually shy away from using intramuscular injection. That will be a last resort. Any kinder ways. Okay, somebody is
intranasal dexmed or midas, oral midas as pre-med and then proceed.
Yeah. Oral midazolam.
Or an intranasal dexmed.
Dexmed. Okay.
If so not available.
Yeah, absolutely. So oral midazolam in a little older child, I would be little wary. And again, 30% of children will not have anxiolysis. They may have paradoxal agitation. What is to say that your child is not in this 30%? So I want to use one medication which will sure shot work. So my go-to, okay, let me see the other answers before giving the parental presence at interval. Oh, super anxious parents. Parents are only very, very anxious. This may work, be counterproductive. Intranasal Dexmed 1 microgram per kg. Fair enough. Showing video mobile use. This child doesn't want to see anything video. He just wants to go home. Any other Any other answers, or shall I go on? Shall I?
Ketamines way of boosted.
Intramuscular ketamine.
It's nasal.
Intranasal ketamine. Okay.
The child to hold with any parents.
Sorry, sir. What did you say?
The child to let the child to hold the parents.
Child should hold the parents. Okay. So thank you everyone for all those responses. So let me see. My answer may not be the most ideal. You can have your differences because everyone has a different way of doing things. But let me see how I would. So I agree. One response, preoperative anxiety management. I would definitely ensure a good pre-anesthetic check. So this is where, our fellows usually give us a good heads up. They will go, they will see, they're usually the first point of contact, and they'll put on the group, super anxious parents, fussy child. So that itself gives us an idea. So here again, with the previous history of ED, child is very, hyper, we would do a good PAC. So here is a time where you can counsel, you can talk to parents, you can talk to the child. Definitely, it might go a small way in reducing the anxiety. And sedative pre-medication for sure, this child, because again, my go-to will be either intranasal Dexmed or oral clonidine. Now, oral clonidine can delay discharge, but this is a child I'm not really worried about, discharge. It's okay. Let him stay a little later. I'm okay, but I want to prevent, another emergence delirium, and they had a bad anesthetic earlier. It's okay if we can stay in. I would go with oral clonidine simply because it is tasteless. And usually children who are fasting, they will be okay to take that oral this thing. We do it for our autistic children who will otherwise not, manage with anything. They may spit out other things, but a tasteless, clear liquid, you just give clonidine in water, they will usually take. But if the child is okay to take Dexmed intranasally, that is another very good option. Some child will, I had a child coming to me who would come like this. We ran around that child for 45 minutes, trying to convince her to take intranasal Dexmed. And this was a child who had come for extraction of 2 teeth. 10-year-old, perfectly normal child, probably had some bad experience before, and she was like this. How do you put intranasal Dexmed? So here, if you have counseled the child, or maybe talk to the parents also, you just sneak in that, say sips of water you can give up to 2 hours. So 1 hour before, you give that clonidine with the thing. So you would do it in the room before the child even comes to the preoperative wing. So this is one way of doing it. And again, I would use TIVA. Because I know this is a problem, this is going to be a problem, I would avoid sleep. So I will induce, of course. Now here, if I've given this pre-med, child will hopefully take the mask nicely, induce with sevoflurane. Sometimes some children even will allow IV line. So it depends. The good IV, you can take in the pre-op only. You can put Prilox. The child doesn't, it doesn't hurt when putting the IV. But if the child is not happy with that Prilox and IV, you can just do it under sevoflurane, take the vein in and do it totally under propofol. I would ensure that pain is taken care of. Now, in adenotonsillectomy, pain can be quite, difficult to take care of. That sore throat and all, it's quite problematic. So use multimodal analgesia, fentanyl, diclofenac, paracetamol, magnesium, local anesthesia. Ask the surgeon to spray the fossa with glucosamine and allow recovery in a quiet environment. So this is how I would manage my case. Any further thoughts on chat? Should I look it up? How to prepare oral clonidine is a question. So basically, we have the ampule, which we use for your regional and all. It's the same thing. So it is 150 mic ampule comes, and you just use it. 3 mics per kg is what we give. Okay.
Sure, just answer your question, madam. That is a 6-year-old, how to manage in ED. That is, he will go for a video game, dragon video game in the preoperative area.
Okay. Okay.
And Naresh Paliwal has answered in the intranasal Dexmed.
Yeah, a lot of people are using Dexkit. I personally don't feel the need to combine, but it's okay. I suppose if it works for it works. That also is a good option, I suppose. Coming to our question.
We finished the presentation. We will take up the questions in the last.
Okay, fine. So this is the last slide actually. So coming back to our quiz question, what is true about emergence delirium in children? The incidence is least in children is obviously false. It is maximum in this age group. Threshold PEAT score to diagnose ED is more than 10 is the correct answer. Incidence is less with sevoflurane compared to desflurane. There is no difference. It is equal between sevoflurane and desflurane. And the incidence after inhalational anesthesia is less than 1% is clearly false. So in summary, ED is common between children in the group of 2 to 6 years or so. The occurrence can be reduced by adopting a low ED anesthetic technique. ED, mind you, is a diagnosis of exclusion. And the most effective regimen includes anxiety reduction preoperatively, alpha-2 agonists, and propofol. These are my references. Thank you.
Thank you very much, madam, for a wonderful presentation. Then we will take up the questions in the chat box. Over to Sarva, madam.
Thank you, Nandini ma'am, for that wonderful and interactive session and making us all realize that ED is not just that 15-30 minutes issue. It can have long-term effects also. And it can be deleterious for the child and for other people and for the surrounding children also, not just for that particular child. And just few clarifications or few more points if you want to emphasize on the question on like how clonidine has to be prepared. That question was asked again, ma'am. Just if you can repeat.
So clonidine comes in an ampule, no? It is 150 micro, in that ampule. So you just take it, we take it in 1 ml syringe so that we know exactly how much. Say your child is 30 kg, you want to give 3 mics per kg. So we'll take like that and you will put it in a glass. We usually put it in a glass, put some water also. So then tell the child you can take sips of water. And clonidine, but you have to give 1 hour. Minimum you have to give 1 hour. So what we do is, moment child has got admitted, we would have done all that preparation. Sister has to tell us child has got admitted and we will go there and give and then shift the child after 1 hour to the recovery.
I think Dr. Bhuvanesh should have got the answer no, they asked for.
Yeah.
And how do you give intranasal Dexmet? It is again using that nasal atomizer?
No, we don't have a nasal atomizer.
1 ml syringe.
Just 1 ml syringe, squirt it, and it is such a small volume that the children will allow. Mostly, they're used to that Otrivin drops.
Yeah.
Some Moisol drops and also they will tell. And very often we tell parents only. We are just cleaning the nose and all, and parents will put the drops and again
15 to 30
half an hour.
15 to 30 minutes prior.
But again, it's a sure shot. It will work.
Yeah. 1 to 3 mics per kg around.
I give only about 1 to 2 mics per kg.
Okay. Intranasal Dexmet alone as an agent for like NORA for pediatric MRI and all. There have been publications like that also.
Yes.
So
you can. So if there is no contrast or anything planned, then you probably can get away with only that. But it all depends. Sometimes you do that and then they also prefer to take an IV line in case you have to give something. So that way.
Okay. And of late there has been a lot of incidents of emergence delirium, mainly because of the agents that we use, the sevoflurane, which was not there before, as you had rightly pointed out. It was not there when we used ether and all. That was mainly because of the differential blood gas solubilities and the rapid recovery. The rapid recovery is because of some differential areas of recovery in brain also, like the parietal cortex recovers faster than your cortical functions. So like the auditory function recovers fast and there's no integration mostly in children. So that is the reason, like different areas getting recovered at a different pace, and the auditory recovers fast, but the prefrontal area recovers slow, and they aren't able to integrate the senses, which the inputs that they receive. So
absolutely.
I just wanted to ask if that
is. You said it so beautifully. I'm just listening. Nice. That is actually so the auditory senses recover faster. And probably in the child, because of the immature synaptic works, there is a sort of imbalance there between.
So, like if we start with sevoflurane and then if we go on to continue the anesthetic with isoflurane, is it the same as like starting with sevo and going on with the?
So all inhalational agents will cause ED with the exception of halothane. So even isoflurane can cause. Okay. So if you really want to prevent ED, then you have to do something else, like, so propofol at the end, Dexmed at the end, something like that.
Yes, ma'am. And
Madam, is there any long-term consequence of ED?
Is there what?
long-term consequences, I think ma'am told it.
So they say that it is not as self-limiting as it is, believed to be. So up to 2 weeks, children have had these maladaptive behaviors and all, they will become clingy. They can have a new onset enuresis. They may have temper tantrums. They may have, eating issues, sleep issues, things like that. And I think overall, even though maybe more than 2 weeks they've not talked about it, we don't know, honestly. But at the same time, there is such a bad this thing about the anesthetic. The next time the child or the family comes for some surgery, they are going to, remember this. So overall, your whole, the whole experience of anesthesia is not going to be a good one.
Thank you.
And, any other questions? Like bioavailability of buccal is more, instead nasal is preferred.
What's the suggestion?
Yeah, so I think that the person is talking about Dexmed only.
Dexmed, I guess, ma'am.
Or maybe midazolam also, because even midazolam can be given buccal. So how you give buccal is you just pull out the stick and you instill it there. But in my experience, the child is not opening
Not
mouth.
going to allow, yeah.
Then why you want to do that? He may not even allow that. He will spit that out also. So buccal has to be retained in the buccal fold. So then case you have only option but to give nasal.
In the management of ED, that single shot of propofol is enough to manage that episode of ED, ma'am? Or do we need to repeat it after some time?
No, usually no. Just 1 milligram per kg propofol, and that takes care of it. Probably because that will work at least for 15-20 minutes. And ED is
so that is the time usually.
That is the time.
Thank you so much, ma'am. Thank you for.
Is there any way to safely induce with the inhalation agent other than sevoflurane to avoid ED?
If you have to induce with the inhalation agent, it is only sevoflurane. No, we don't have an option.
You can give propofol and reduce the dose of sevoflurane like that.
During induction. During induction, so if you're inducing with sevoflurane, I believe you may not have an IV.
Not have an IV line.
That is why you're inducing. But even if you have to induce with sevoflurane, which most of our inductions are like that only, because most of the times child may not have an IV, especially for all these daycare surgeries. So we do induce with sevoflurane, but we have everything else to take care of ED. So ED can be really, actually we can, predict. If you're doing only pediatric anesthesia because you've burnt your fingers so often that you can predict and you can kind of prevent. So most of us, what we will do is at the end of the anesthetic, we give propofol, always 1 milligram per kg, whether we think patient is high risk or not. Most of our 2 to 6 year olds are high risk. So we will give that small dose of propofol, and we don't really want them completely awake. We're happy that they are breathing, maintaining reflexes when we take out the tube or the LMA or whatever.
Mocha or Doka ice cubes by Dr. Tushar Choshki.
Oh, I don't know what this
I don't know what it is, ma'am. I think it's midazolam, ketamine. I don't know what.
Mocha is a preparation of Tushar.
Midazolam, oral ketamine, I think. Midazolam, oral ketamine. What is A? I don't know. Acetaminophen. Acetaminophen. Dr. Tushar, can you explain what it is? Is it midazolam, ketamine, and acetaminophen?
Okay, I want to highlight 2 things. When I'm inducing an inhalation agent, I am having my friends, pediatric anesthesiologists from USA, and he has suggested one thing, that how they are doing induction with sevoflurane anesthesia. They have a dragon game for dragon anesthesia when the child is in the recovery room and they are playing the video game where the dragon is inhaling and exhaling in the video screen, and at the same time the child is instructed to inhale and exhale in the mask, but that mask is containing sevoflurane. So the child is properly instructed that how dragon is inhaling and exhaling that in the video screen. You have to do this exercise, and within 3 to 4 breaths the child is coming under the anesthesia. So that are following in so many pediatric department of anesthesia in all over the country in USA, and that I liked it, but it is not available in India. And second thing, in my practice since last 20 years, I am following Mocha ice cube in my all ENT surgeries where the tonsillectomy and another pediatric anesthesia, where I prepare ice cube of ketamine, midazolam, ondensetrol, ondansetron and atropine mix, and I give it to up to 2 years, more than 2 years to 15 years of old child at the dose of 1 ice cube, 2 ice cube, 3 ice cube, and I'm comfortably, my child is sleeping. At least they will be distracted from their parents and they can be put IV line. So this oral ketamine and midazolam works very well. Child is not able to take at least oral suspension, but so that's why I develop a mocha ice cube. So ice cubes are very good combinations of this, and in my practice, almost all the patients I'm doing with 1 hour before this mocha ice cubes, and I'm comfortable. Even I can, it's a pre-medication, novel pre-medication before going to anesthesia. And now I have changed over from midazolam to dexmedetomidine. So in that part, my child is comfortable, and I have to give little bit dexmedetomidine or propofol or ketamine to induce that patient for tonsillectomy or any urological surgery or something like that. So in pediatric anesthesia, I want to highlight the oral preparation of other agents. That's the way.
Okay, how do you prepare that? Like what dosage? How much you prepare in one?
That is the
One ice
same
cube
dose.
is how much?
That is the same dose we are doing in the oral preparation. Like ketamine, we are using 5 to 10 milligram per kilogram. Then dexmedetomidine, if we are using, then 1 milligram per kilogram. And naturally, midazolam 0.1 milligram per kilogram. Then other things, ondansetron. All these preparations are available orally, and we can use from even injections to prepare ice cubes. And for palatable purpose, I am using sometimes the orange juice or something like sugar juice to add. And more than 500 patients I have completed. And now, since last year, I have switched. Even this works very well in the NORA situation also. When there is a small things are going on, patient should not be given full anesthesia, but just heavy sedation, that's all. And in that part also, the hemodynamic status is stable. Thank you.
Thank you. Thank you so much, sir. Thank you.
For your contribution.
Thank
You
you.
do publish.
Yeah, I have. This is available in the net also, this paper.
Thank you, Tushar, for your contribution.
Thank you. Thank you.
Over this, so Vinothini.
Thank you, Nandini ma'am, for that interactive session,
Thank
for
you.
making us all realize the importance of emergency agitation and delirium and the ways to tackle it. Thank you so much, ma'am.
Thank you. Thank you for having me.
Thank you, madam. We'll go to the second session.
I call upon Dr. VRUSHALI PONDE, ma'am. She is the Director of Children's Anaesthesia Services, Mumbai. She is the Program Head of WFSA Children Anaesthesia Services and the ISA Paediatric Regional Anaesthesia Fellowship, Mumbai. She is in the Education Committee of WFSA Paediatric Anaesthesia, and she is an ex-president of Academy of Regional Anaesthesia. She has many honors, and she's part of the AORA and the CAS Paediatric Regional Anesthesia Fellowship Program. She works as a regional anesthesiologist and a pediatric anesthesiologist in various institutions in Mumbai, and she has got so many publications to her name, around 85 international and national research publications. And she's an author of the book Illustrated Manual Ultrasound Guided Regional Anesthesia in Adults and Children. It's been translated in Japanese language also, and she has represented India in various regional anesthesia perspectives. So she will be the best person to speak on the pediatric regional anesthesia. Over to you, ma'am. And she also is a good sitar player. So hope we can hear from her regarding sitar also sometime later. Over to you, ma'am.
Namaste, and an extremely joyous morning to all of you. And Vinothini, I'm almost beholden to you. What a fantastic introduction you did. Thank you so much. Well, now let's get along with the topic here. I am trying to share my screen. Can everybody see the presentation?
Yes, ma'am. Your voice alone seems a bit lower, ma'am. Can you increase your voice?
Now am I heard?
Yeah, fine.
Better? Better?
Yeah, clear, loud and clear.
Okay, all right. Now what I'm trying to do is I'm trying to see my own slides. You can see these slides?
Yes, ma'am.
Yeah, we can see.
Slides now?
Yeah.
All right, wonderful. So, yes, I take the baton of pediatric anesthesia ahead. We come to another important factor that is almost intertwined today with pediatric anesthesia, as such, which is pediatric regional anesthesia.
Yes, it has kind of formed its own niche and its own way of teaching, and it comes of course after having the basics of pediatric regional anesthesia founded extremely well. So let's go ahead and spend some good time, and I'm so delighted that for once we have 45 minutes given to a pediatric topic, because the moment we start in a regional anesthesia work as such, pediatric anesthesia would be regional anesthesia would be given some point, and we need to cover everything in that particular 20 minutes. So I'm going to enjoy myself, and I hope you all do along with me. I want to share one of my patients' WhatsApp with you with her own consent, of course. So prior to that, I want to say something. We all are anesthesiologists here. There are PG students as well. Remember, if we all live as much as we are expected to live and work around say 8 hours a day, we spend around 80,000 working hours in our lifetime. Well, if you want to add a good meaning to it and truly have fun doing what you do, I guess we need to really like what we want to do. And just not like and remain there, but see how much we can evolve and be our best when we give our patients whatever we can offer. So this is a small WhatsApp that I want to share to begin with, just so that we energize ourselves to look into something even better than what we could do. And we all are together into this. So she said that, dear Dr. Ponde, my son was undergoing a minor surgery and my pediatrician was very keen to set an appointment for surgery based on your availability. Well, I was in cloud 9 when I read that, because in private practice, it's the other way around. As he said, you are best with kids, because we love kids, and that's indeed is true. So it was very nice of that pediatrician tells how much teamwork goes in, because regional anesthesia is not just in the OR. It has to go to the pediatrician, the neonatologist, the PICU, the surgical team, and of course the parents. They all have to be in your team. She further added, my son was so comfortable with your presence itself. Yes, Nandini said, go reassure. First of all, one eyeball, and you're going to come to know the family, what they would want from you. Give the information as much as it is required, even as far as regional anesthesia goes. So don't overwhelm them. Just be your natural and be calm yourself, so that you can percolate that calmness in them. So and listen to them. I guess if you are very patient and listen to them, you come to know all that is expected from them as in terms of behavior, and they need to know what to expect from us. So my son was so comfortable with your presence itself, that made everything else so easy. And thank you, Dr. VRUSHALI, for looking after my child so carefully, as I understand how important the effect of anesthesia is during a surgery. Thank God. And I mean, she wrote this to me. Well, there was a reason why I have posted this here. The PGs are here, I was told. Go home and reflect on this, because it will never happen that you don't do work to get a reward. But if you do good work and enjoy it yourself and see to it that you're pleasant around, all this becomes a byproduct. And by the way, just on a lighter note, she's Mrs. Pople, and she owns a big jewelry chain here in Mumbai. So my declarations to begin with is, yes, I am biased towards the subject that I'm being told to speak on, and I have the conflict of interest with those who don't think that regional anesthesia and pediatrics is important. And I like movies. We will come to that why. So the agenda is going to be as follows. Why pediatric regional anesthesia? Why am I given 45 minutes to an hour on a Sunday morning? What are the fundamentals of RA? No, let's not go to the blocks. Let's first understand this. What are the must-know everyday blocks? Because there are certain occasional pediatric anesthesiologists, and what are the cutting edges for those who are practicing it day in and out? What are the complications and controversies? Nothing. No astute decision can be made unless you are aware of complications and controversies given for a given topic, and the take homes that we can take on this. Coming to benefits of regional anesthesia, they're staring at you, but this article is extremely elaborate in telling you the benefits of regional anesthesia as such. It's written by Professor Bosenberg, and the PDF is free to be downloaded. So yes, you can all read. Let me, however, give you the gist of it. It's safe. You know what the magic here is. Unlike adults, pediatric regional anesthesia is given in either asleep or general anesthetized patients as such, and yet it is safe. So yes, there is an inherent safety factor here, whereas the adult world is like still contemplating whether we need to give sedation or how safe are they to be given under general anesthesia, especially the neck blocks. So well, this is how it is. Here we've rested the case long back for obvious reasons. Then pain relief, of course, obvious reason. Reduction in anesthesia requirement, GA sparing in an atmosphere where now we're talking about general anesthesia having detrimental effects on a newborn brain or immature brain. This has come forth in a very different perspective. Physiological benefits, we shall look into them. Post-defense mechanisms are better, and economy, of course. Yes, we let go of so many other things, and of course, you spare GA, you spare some money as well, and local anesthetics and a needle, and perhaps one-time ultrasound machine. It goes a long way. We've proved it by a proper study that yes, it is economical. So let's come to physiological benefits. Yes, there is analgesia, and the benefits of analgesia itself: reduce need for postoperative ventilatory support. They get weaned a little early because you give them analgesia by giving continuous catheters. Hemodynamic stability, very inherent again, and reduced hormonal stress response because there is no surgical response as such. And then reduction in intraoperative blood loss. There is a hypovasculature. A hypovascular field is very, very typical of a good regional block. An astute surgeon who's worked a lot on either side shall tell you that. Well, let's come to basic principles of pediatric regional anesthesia, and let's build our foundations right from here. There are certain differences in anatomy, physiology, and pharmacology of neonates, children, and adults that needs to be synced into us to pick up pediatric regional anesthesia and work ahead. So let me just go through them. Let's look at myelination, what happens in neonates, children, adult, but let's not look at that. Let's look at the clinical implications of it as well. Myelinations in neonates, very immature. In child, well, it's completed till 10, but remains immature. In adults, the myelination is complete. So what are the clinical implications of it? Well, clinical implications are LA rapidly penetrates into the nerves, producing fast onset block. A low concentration is what is required for a dense block. So just remember this. And now let's come to endoneurium, loose in neonates and children and relatively firm in adults. Greater spread of LA produces a fast onset and high quality block. LA is absorbed quickly away. So in nutshell, we get real solid blocks in low concentrations. The onset is fast and always the recovery is fast as well. Vasculature surrounding nerves, there are rich vasculatures in smaller age groups and less vasculature they're less vascular around in adults and even lesser in geriatric population. Age-related differences, mind you, this is something that we really need to understand, especially for the central neuroaxial blocks, the termination of conus medullaris. We all think of dural sac more and conus medullaris less, but if you want to practice spinals, we need to do a close thought on conus medullaris in neonates L3 and L4 or L4, and for till 1 year, L1, and in adults, yes, of L1. Termination of dural sac, again, very important. S3 or S4 in neonates ascends a bit, S2 in till 1 year, and then S2 it remains in adults that way. Well, curvatures, let me tell you the nutshell of this. Curvature, in neonates, it's straight. As the child starts walking, you get the lordosis. But prior to that, the cervical curvature gets established because the child starts lifting his head, as it were. So cervical first, lordosis then, and then of course it it's thoracic kyphosis and lumbar lordosis is present in adults by that time. What are the clinical implications of this? In neonates, caudal can become a portal to thread your catheters up till the thorax or increase the volume, reduce the concentration, and then you take the amount of local anesthetic and expect it to reach till the thoracic level. Not in older children, because the lumbar lordosis is going to sink your local anesthetic right there, and you're not going to get lower thoracic, neither higher thoracic from the caudal portal as they grow. Vertebra cartilaginous. Later on, they ossify. Ultrasound windows very open here. Sacral vertebrae, incomplete fusion. Caudal portal open for you. 1 year, it's still open, but definitely by 7 to 8 years, it's closed by fibrosis, but not impossible to really look into it, palpate it, and go with a needle inside. But however, the blocks can be patchy here. So I know the slide is busy, but what we can do is we need to understand how all this has changed our ways of performing blocks. Because say in neonates, there is a higher risk of dural puncture because we know that the dura is lower down. In all age groups, surface landmarks influence the level of needle insertion. Now we know where the conus medullaris is. In adolescents and adults, a steeper needle angle is required, whereas in neonates, just go straight, especially at least when you are going to lower thoracic levels. In infants and neonates, there is an increase in cephalad spread that I already told you, and lordosis limits it. In neonates and infants, sharp needles may traverse into bones, remember this, and damaging ossification nuclei, something that matters to us there and then on table. The sacrum of a neonate and infant is going to be so supple that for a person who's too used to the ligamentum flavum of an adult or a school-going child, it's not going to be any different. And the local calculated for a caudal epidural now can go into the intraosseous plane of which is just beyond the sacral bone, and now you're going to convert an intravascular injection. There is hardly any difference between intraosseous and intravascular injection here. So that is the importance to know what happens to the cartilages. So short bevel, blunt tip needle, hence are better. Neonates and infants, there is a better ultrasound visualization, of course, and sacral hiatus as a portal is available only till 8 years or 7 maybe. Then sacral epidural approaches are possible until complete fusion as well. So let's see how this goes. Now, drugs and dosages, it's extremely important here. Well, I know, again, there are 2-3 columns. Just remember one thing. For peripheral blocks, 0.5 ml per kilogram of 0.25% levobupivacaine or bupivacaine or 0.2% ropivacaine, always safe. When it comes to caudal, we need to go by ml per kilogram depending upon where we need to reach with it. We'll come to that once we start dealing with the central neuroaxis. Coming to common adjuvants, the list again is long, but in practice, we just pick up one clonidine, 0.5 to 2 micrograms per kilogram. So this is that one drug that we would pick up if we need to give adjectives, and adjectives are always welcome. Anything that prolongs analgesia is welcome. So deep calculations are required here. So which are the everyday blocks, as it were, and which are the real cutting edge blocks that you can hone your skills as you are done with the basic blocks as such? Well, let's come to the central neuroaxial blocks. We'll go to the upper extremity, lower extremity, trunk, penile and ring, and then let's come to the latest blocks as such. Coming to caudal, there are 3 things about caudal. Well, it's simple. It's simplicity of the caudal that has really kept it going till now, and I guess it's here to stay. Simply because it is simple to give. It picks up huge number of indications, right from the toe till the lower thorax. It can clearly be a very, very versatile block to give. It can be given as loss of resistance. It can be given as PNS. Loss of resistance would be palpate posterior superior iliac spine and then one finger, try and make a so-called isosceles triangle, arguably palpate the sacral hiatus and then get in with either a hypodermic needle or a PNS needle, and then get going with stimulus here, and then motor response is perianal twitch. Now let us spend some time on this particular video as such, and let us understand why should one ever take any trouble of going through this particular modality for a simple caudal, which we claim is actually a very, very simple problem. Well, now you take a hypodermic needle. Once we traverse from the insertion point inside skin, subcutaneous tissue, get a give of sacrococcygeal membrane as such. Yes, of course. That is a very objective phenomenon. No, that's a subjective phenomenon. Depends upon the expertise of the person who's giving it. Depends upon how many blocks he has given before. However, still remains an extremely easy technique to do. Extremely easy thing to actually perceive. You start giving, you see a bulge there. So we know that we are in the skin and subcutaneous tissue. So if you really want to be very sure that your needle is amidst the phylum terminal and add an objectivity to it, pick up a PNS needle. How would you use it? Yes, activate your PNS circuit, but be at higher currents. How? 4 to 5 milliamperes, and then get going in it. Or you could actually get the give with the PNS needle and then on the current, go to higher currents. At lower currents, you're not going to get. At 3 to 5, you get that, elicit the end motor response. You might see even the toes moving around. Toes could be also end motor responses. What information have we got? We are very clear that we are in the phylum terminal for sure amidst the roots of it. Okay. Now what additional information can we get? Now reduce the current. If you start getting it as low as a 0.3 or 0.4, which we are so conditioned to look at when it comes to peripheral nerve blocks, if it happens, be sure you have gone through the dural sac and the tip is sitting inside the CSF. So this is one way of being very sure that you're not going to create complications at least. If somebody wants to do that, yes, it is most welcome, and definitely it gives you one thing for sure. So this is what PNS is adding. Now, what more can you do with caudal portal? Take a 19 gauge epidural, give it as you're giving a single shot caudal. Dilate if you want with normal saline, not necessary, but just that it becomes easier to thread a catheter. And this becomes a portal for your catheter insertion, and the tip of the catheter can be kept at the surgically congruent vertebral level. So this is what caudal portal can be used by just landmark or PNS guided. We do have caudal stimulating catheters as well, even epidural stimulating catheters, but in pediatrics, it doesn't really work in a cost beneficial manner. So one-time ultrasound is probably a better option to go to. Now, let me introduce you to the world of ultrasound and neuraxial blocks as such. If you want to really understand ultrasound spine, and if there is any one place to start with it, then come to ultrasound-guided central neuraxial blocks in infants and neonates. The anatomy shall be so open that get this anatomical concepts and go to your adult practice, and it's going to really aid you understand that difficult anatomy there. Here, the anatomy is easy, but you need more dexterity to work at that superficial level. So, well, let's go ahead. So, this is how it would be. I am just showing you the probe movements. It could be straight. When you want to do a longitudinal scan, you may not be parasagittal as such. You may not be, or you could be, but here, remember, we just realized that the ossification hasn't happened, so you can be bang on the spines, or you can go a little ahead, little lateral and turn inside as it were to look through the lamines inside the central neuroaxial conduit. You could do a transverse scanning as well. So this is how you can slide your probe up. Actually, the orientation marker doesn't matter here because you are going to really not give a peripheral block, it matters there more. you're going to anchor as posterior and anterior more than lateral and medial. So this is how you will scan. Now let us look at this perfectly, because if you want to understand ultrasound central neuroaxis, this is something that this is that one video that I would want all of you to realize, understand, and go back. So go back in the sense, yeah, you stay at home, but this is one thing that I really wanted to percolate in you. You've seen the probe, now you see what the probe shows you. So here you go. Anchor, anchor, anchor yourself. Posterior, anterior. Orientation marker, longitudinal. Be sure the orientation marker is caudal. Want to keep it cephalad? Keep it cephalad. As long as you know where the orientation marker is, you're fine. Now let's go ahead. Here is the skin and subcutaneous tissue, understandably very, very thin. Then you come to another way. You can see all this. These are all white lines, right? So this is the phylum terminale. Let me not jump to phylum terminale. Let me go layer by layer with you all. Can you see this? 1, 2, these are all sacral spines. And this is a sacral spine as well. Is it really hindering the posterior dura here? No, it isn't. So this is the posterior dura. This is the roof. This is the floor. Again, these are the sacral vertebrae. So here is your roof. Here is the floor of the sacral vertebrae, and this is the caudal epidural space where you're going to work in. These are the phylum terminales, and here would be somewhere the sacrococcygil ligament. Not really, can't really pinpoint it, but this is how the needle will get in. And this is the CSF. So if the needle goes further down and really gets into here, then you're actually creating the most deadliest complication of caudal epidural, which is a total spinal, in other words. So anterior dura, posterior dura, and this would be the anterior epidural space, and this would be the posterior epidural space. So having told you this, let's go ahead and see the video even further. We are descending up. Can you see this? This is full of liquid. So this is CSF, the posterior dura, the anterior dura. Could you see the hyperechogenicity here? This is the ligamentum flavum, and this could be the epidural space. Let's be a little more diplomatic and call this the posterior dural complex as such, because it's very difficult to really say where the ligamentum flavum has ended and where the posterior dura has really started, and where is the epidural space in between the two. Well, once the drug starts percolating, it is going to peel both of them away. But still, most likely, these are the two structures which are pretty different. And we can say this at least to some certainty in this age group. Once they become adults, impossible. Be politically correct there and call it as the posterior dural complex. This is the anterior dural complex. So this is the anterior dura, and this is these are all the longitudinal ligaments, and this is the posterior aspect of the vertebral body. So is this very clear? This is the central glial tissue. Now let's go ahead. You can see the central glial tissue. Now we are in the lumbar region, as it were. And hold on. Let me hold this video. Can you see another cone as it is here? This is the conus medullaris. So now you can even see where the actual spinal cord has begun. Now let's go ahead and see that. Now let's trace it ahead even further. We go ahead. Watch the conus medullaris. Let me ask you all, are these ultrasound videos very clear to the audience here?
Yes, madam.
Yeah.
Okay, lovely. That's very reassuring. Now let's go ahead. Go ahead in the sense we are going cephalad. We are going cephalad even further. Trying to be very sure of the conus again. Now we are back at dural sac. So we got the entire idea of the dural sac, then the conus, and then how the whole thing proceeds. Let's come to the transverse section before we really go to interventions as such. Transverse sections in a baby, a very small baby is going to look like this. Not a very good image. Let me go a little ahead and and get the image for you. Yes, let me hold this one. Let me hold this one. This is the posterior, this is the anterior. Can you see that there is a little loss of image because the footprint and the skin are not in contact. The child is a little small and the probe is a little the child is a little big and the probe is, sorry, the other way around. The probe and the skin aren't sitting with each other. Okay, the probe is in the air, but some part of the probe is really sticking and giving us this image. Posterior, anterior of the body. Can you see the two sacral corners? There is a slight shadow of the sacral corner here and here, but not much. And now you can see the sacrococcygeal ligament, which is for sure a structure which actually a needle is going to traverse through. This is the epidural space, the potential caudal epidural space, and this is the base of the sacrum. Another dreaded complication of an intraosseous injection, in other words, intravascular injection, is this. If the needle goes through this here and is then you obviously are going to head for trouble. And sacral osteomyelitis, of course. So here is the place where our drug deposition is going to happen. You will see this as if it's been tethered by the needle, and then you come inside and start injecting the local anesthetic and see the hydrodissection happening here. So now let's go ahead and can you see these? Can you see these nerve endings? They are the ones. This is another typical frog sign. Sacral cornu, the loss of image is a little less. This is the potential epidural space. This is the base of the sacrum. Have it sink in your mind. This is the pattern which you are going to see. Now we are going a little more ahead. We are going in the sacral area. This is the sacral area, still sacral area. Let's go a little more ahead. Let's go a little more ahead. Now this is still higher sacral area. The bifid spine is here, but we are getting the formations of the conduit. Yeah, now we are almost in the, hold on, now we are in the lumbar area as such. So can you see the entire spinal cord? Let's go a little ahead and freeze here, a little more ahead. Wait, I won't let you go till you see a proper, yes. Yes, let's halt here. Let's halt here and ponder on this image even further. Posterior, anterior. This is in between the two spines. Even if it was on the spine, you would have seen this. However, if you want to choose a space to get into or want to watch a space that you want to, you would count and be here. So this would be the posterior, anterior. This is the entire intrathecal space, and you can see the H-horns here, and you can see the formation of the nerve roots here. Can you see them? And you can see actually the dentate ligament. Then you can even see the lamina. Actually, this is the lamina. And if you go a little ahead, when you are in between the two spines, you see the transverse process. If you are on the spine, you always see the lamina. Here it looks like a lamina. Laminar view. Yeah, here is the transverse process view, a proper transverse process view. Now you can see that these are the nerve roots, the horns in between the intrathecal space. This would be the ligamentum flavum, and this would be the dura, sorry, the ligamentum flavum is somewhere here, and you would get your drug or the epidural catheter in a transverse section as if it was a hyperechoic dot right here. And these are all the nerve roots that are about to form and exit from the foramen. So this is how it would be. As you go higher up, you would see that the lungs are moving around. You would see the pleural movements. Can you see the bigger nerve roots forming? Yeah. Now we are coming higher up. We are ascending into the thorax. And you will start seeing the movement of the lungs. Now, this has changed a bit. The matter inside is more inside the intrathecal space. And the nerve roots are seen here. And you can see the CSF cushioning the intrathecal space. This is the intrathecal space. This is the CSF here. Okay, so this is actually the beauty of central neuroaxis ultrasound. This is again the dentate ligament. Can you see how it is holding properly the entire structure? So that's a good scaffolding formed here. So this is the image, or this is the video that you really have to sink inside yourself if you want to understand the process of central neuraxial blocks. Let's come to the interventions. If you want to really teach ultrasound, or follow somebody doing it with a landmark. So this is the dural sac. We are very sure about that now. This is the needle approaching in a baby. Yes, we've dilated the anterior epidural space with the drug, and there was a wee bit of air in the hub of the needle which sabotaged the image. These are all teaching videos. One can go very, very close to the dural sac, ask them to withdraw, and then inject. A little bit has gone on the posterior dura as well. So it becomes a bit tricky when you're teaching in neonates, especially for a person who has just come to learn with you. So there should be a couple of months in infants and older children. So let's go to the older children. So this is the phylum terminal again, roof and floor of the sacrum. See how the anatomy has beautifully changed. The depth has changed. We are working at 4.9, maybe even a lesser depth would have been okay. Now the injection has started, and you will see the posterior and the anterior dura coming together because now the drug is seeping all along. The drug is posterior to the posterior dura and anterior to the anterior dura. Now see the posterior dura. When the drug reaches here, you will see the posterior dura falling and the anterior dura coming towards the posterior dura. So the anterior dura gets lifted, the posterior dura gets depressed, okay, pushed down. So this is what is the seepage of local anesthetic in the central neuroaction looks like. And if you can see this at the surgically congruent level, you're very sure your block has reached there or your local anesthetic has reached there. So go back to the PNS side. PNS video told you that you are in the phylum terminal and that you would go inside the CSF and get it at a lower current. Now, this video is going to tell you that it is a surrogate marker to be sure where you are, and you're not just sure of where you are, you can be at the surgically congruent level along. And if you aren't, you can dilute your local anesthetic a little more, give it or see after some time because it's a pulsatile structure and it might carry a little ahead. More than that, you can actually see the catheter tip. If you have given your block a little, with this exactitude, you can actually get the surgery done in a very, very lighter plane. It's a vasicostomy done for a high creatinine level, and look at the surgery, the anesthesia depth as it were. The child is just given a whiff of sevoflurane as it were for immobility, and the operability is given by the regional block, the caudal epidural. If you scan a lot, you realize that in prematures, the dural sac is even more close. So please be very, very, very sure, very, very sure of coming into prematures and neonates only after you have practiced a lot in older children and infants. Well, coming to the volumes, we get our caudal blocks on volumes. Lower limb and penile, 0.5 ml per kilogram. Herniotomy, don't underestimate, it's not below the umbilicus, it is actually lower thoracic. Go to 1 to 1.25 ml per kilogram because the dermatome is that way. Lower thoracic, again 1 to 1.25 ml per kilogram. And please note the concentrations, we've decreased the concentration. So let's reflect on what we have learned. How do we assess that the action is truly on? Anybody on the chat box, can they just put it across? Or anybody can just open and talk to me. I mean, we've given such a block. So how do we make sure that it's acting still, and how do we know that it's acted? Yes, no increase in heart rate following. Yes, wonderful. Yes, wonderful. Anal sphincter loss. Yes, yes, Anju. Yes. This is all provided. Don't give up on your block unless you have given a soakage time to your pediatric surgeon. Unlike orthopedic surgeons, pediatric surgeons are going to scrub and come and stand next to you while you are going to give a caudal block. So give your soakage time. And if you haven't, then make sure that the depth is adequate when they take an incision, and let the caudal pick up for post-op analgesia or as they go further, because hernias and circumcisions are very short operations. Slight increase in heart rate, yes, possible. So give a good soakage time, and there should not be any increase in heart rate and blood pressure. And yes, pupils is another way to understand that there is a response again after this. And secondly, if you've not paralyzed the child, then slight motor movements are also seen, or increase in respiratory rate. What do you do actually when there is a blood or CSF tap? Yes, pour in. There is a blood tap. Now what do we do? Yeah, we would prevent it, but it's even if you use ultrasound, you may get blood taps. Let me tell you, very small vessels may not be still seen. So what would you do? What should we do? CSF tap, we shall abandon the procedure, I guess. I would abandon the procedure if I get a CSF tap caudal. Blood tap, I would redo it, but I would, if the local anesthetic gets a tinge, I would throw the local anesthetic and do it again. How do we communicate with the family about a caudal? Adjust the needle tip, yes. Remove and take a new prick. But multiple pricks also can give a gush of, I mean, not a gush, but a tinge of blood. How do we communicate with the family about a caudal block? Any clues? Any suggestions? Reinsert flushing, okay, yeah. And watchful of last. Yes, I get that. Okay, let me just share with you how we communicate with our patients when it comes to a caudal epidural block. If they are mothers and if they have taken cesarean section, spinal or epidural, they have that conditioning of, okay, it goes right inside the spine. We have a very kinder way of putting this to them. We say that your baby will be sleeping when we give this caudal epidural block. We say that this epidural is totally different. In children, the space is very, very low down. When the whole back has, the spine has ended, it's just underneath the skin, and it's not too deep as it is in adults. And we would give a numbing medicine through it, which will numb the area of operation, and your child is going to be more comfortable. And I always like to give them the example of a dentist injecting in and around, around the nerves where the whole area gets numb. So they identify this with that simile a little more, and most of them are extremely comfortable once this is told to them. Well, should we be going peripheral? Yes, modern pediatric anesthesia is asking you to go more and more peripheral with regional techniques. Agreed. But then, after having looked into peripheral, please make sure that it has to be a case-by-case decision. Let me give an example here. Ilioinguinal iliohypogastric is a good block for hernia. However, caudal gives a good block as well. So which one would you pick? If I want operability from the caudal, from the entire block that I give, I go to caudal. If I want post-op analgesia, I will go to ilioinguinal iliohypogastric. If a neonate, you inject no matter how little a volume. Neonatal hernias are extremely tricky. You flood their planes, you mess up with their planes. They are going to be flustered while working, and a flustered surgeon is not a good idea at all. So don't tamper with plans of surgeons, but if they are comfortable, go ahead or give it post-op. Coming to common complications, I guess we just have discussed. Last is one complication, and then commonest complication is dural punctures and giving the dose that is calculated caudal block inside the epidural space. I mean, inside the spinal, inside the CSF. So these were other ways of assessing analgesia intraoperatively. Look at this one. Look at this case. Laparotomy, baby, extubated, just on oxygen for transport, an epidural catheter. Can somebody observe something and tell me? One observation from you all. I give you half a minute. Give me one observation of you. Not half a minute, I'll give it 20 seconds. Motor block of lower limbs. Anju, yes. Okay. Anju, you're not going to answer. Okay, fine. So, yes, that's a caudal epidural, lumbar working, and lower thoracic as well, because we would put a tip for a laparotomy at the level of higher than T12 for sure. Caudal catheters, we've seen the videos. Yes, you can go more and more site specific, and they can be traced. So you can see the catheter tip here. I think I'm zooming in. I'm trying to get the zoom out. Well, anyway, I will go to the next video. You will see the catheter moving up in the posterior epidural space, the anterior epidural space. It is free to move wherever it wants to.
We are able to see the catheter.
Yeah. Now I'm trying to stop this video so that I can go to the next slide. Okay. This is an interesting situation where I tap to go ahead and it only zooms. So I need to get out of the zoom and I need to go back to the video. And now I go to the next. Not bad at all. So yes, ultrasound does improve the accuracy of your placement. We do avoid a lot of deep anesthesia and artificial airway when it comes to surface surgeries, mind you. But then what if you really are presented with such cases, such as an absent sacrum, but child is for lower extremity, or you have an absent sacrum, but it's a bilateral ureteric reimplant? What do you do for all this? Well, if it is a lower extremity, you can actually go to peripherals. You actually can go to peripherals even without this. You don't need a reason to go peripherals, provided the indications are good. So coming to lumbar epidural, this is another common block that we can master, and there are certain differences. You use a proper equipment. Here is 19 gauge, and the LOR is typically taken up with a saline filled syringe. So this is how we would go. Watch the steps, because not everything can be actually vocalized. Put a normal saline filled syringe along. The dominant hand holds the needle. The non-dominant hand always gives a pressure on the plunger, and then it is moved as an entire assembly. It is a good idea to have somebody give a gentle counter pressure from the other side so that the back doesn't move much. Once you have elicited the LOR, please be kind to yourself and put in the introducer, because this gauge catheter is very difficult to thread without it, and then thread your catheter inside. But the The fun is when you remove the needle, the catheter tends to withdraw a little, a couple of centimeters. So do opposite actions. Remove the catheter and remove the needle and insert the catheter. So you do get finally the amount that should be kept inside. So here you are. Be steady with your hands and have the catheter there and then dress the thing. If somebody a couple of levels up is watching the epidural, so you need two people here, one to give and one to watch. So this is how it would appear in a transverse section, but this can be done later after giving an epidural as well. We know the transverse section now. So here's the CSF. Here's the posterior dura. Here's the tip of the epidural catheter, this one. And this is the ligamentum flavum. And here is the LA deposition, a pristine hypoechoic or rather anechoic spread out. Now, this is time to go NORRA, NORA. Regionals can be taken in the wards for different purposes. So here it actually is a case of necrotizing fasciitis, and it was, of course, very painful. Maybe whatever vasodilatation given by the block helped, but repeated dressing was something. So we kept the catheter for quite some time, almost 14 days, with a good antibiotic cover. But then, of course, parents, surgeons, the whole team, and us with the responsibility has to be, we need to take that step, a proper consent, and the entire team has to be on board. And then you can do repeated dressings. But mind you, even if they're pain-free, they are not going to really like somebody very close to them and doing this. They're just going to be fearful watching what is being done. So please see to it that they don't watch all this in the wards or even in the OT, minor OTs. So do this and then get going. They'll be a little more comfortable. Coming to upper extremities, we'll go to the axillary block, the most common entry-level block in even children, and indications are also of that kind. Crushes of couple of fingers, but if it's just one or so, then a ring block is good enough. But crush injuries are most common, and axillary block is common as well. This is how it would be. These are the end motor response. The highest level in the axilla, you see the position and then get in with the PNS. You want to really work with ultrasound. This is how it would be. The probe and needle position is right in front of you. This is how the entire neurovascular bundle would look at. Say 12 o'clock to the artery would be the median, 6 o'clock to the artery would be the radial, and maybe 2 o'clock to the artery would be the ulnar. I really will not spend much time in deciphering each nerve. I would simply do this kind of an injection. We have learned from the basics that blocks really percolate very well in kids. Unlike, look at this video, it's an adult, and see the differences between the neural tissues and see the difference between the artery. Well, coming to infraclavicular, the most indicated block actually, if we are really dealing with congenital anomalies and of course supracondylar fractures, especially the open reductions, a good block for them. Again, there is a controversy for that. We'll come to that a little later. Probe orientation is here, the needle orientation is here, and this is the sonoanatomy. This is an adult and this is a baby. So you can see the drug deposition all around, pectoralis major, pectoralis minor. This is the neurovascular bundle. You can see that this is the pleura here. This is the artery, then the lateral cord, the posterior cord and the medial cord. Well, so coming to dual modalities, yes, if you want to teach dual modality, as long as the sonoanatomy is clear, dual modality has no role, but yes, you can start teaching to people this way for sure, so that they understand both the modalities, and this is the typical end motor response. But in children, what we use is the coracoid approach. We do not talk in terms of the lateral and the medial, because the more medial we go, the more are our chances of puncturing the pleura. We always talk of infracoracoid, infraclavicular block, just subcoracoid. How do we palpate a coracoid? Even in a chubby child, coracoid is very easy to palpate. Start from the humerus and come midway and till you go to clavicle. You are going to meet the coracoid bone in between. You would, there is no doubt, use a thumb which has a bigger surface area to palpate that. In any age group of any weight, coracoid can always be palpated by this technique. So it's a wonderful block, and the anatomy renders itself perfect by for catheter fixations. I'll just show you a quick video and we go ahead. Dr. Edward, you'll have to tell me about the time because I get carried away so that I can skip.
Please carry on, Mala. We can take extra time. No
Sure.
problem.
Thank you. So these are the various injections at various locations. So you can see the lateral cord getting bathed, and I'm going towards the medial cord. One more question I'm asking myself. Was it required to go there? Actually not. Go to the basics again. LA percolates in small babies very easily. There are no thick tissues here, supple. So even one posterior injection or lateral injection was enough. Adult population, well, the literature is shouting hoarse. Go to the posterior cord, deposit all your drug at the posterior cord to increase the efficiency and efficacy of the block, infraclavicular block. Does it really hold true in kids? No. Look, go to the lateral cord, it's fine. Do not traverse right till the posterior cord. The pleura is right here. So these are two babies, and here is an adult. Look at the adult. Look at the depth that you work at. You work at higher depths. In babies, you work at lesser depths. But then the pleura is very close. So well, it's very difficult again to put everything in words. What I'm trying to tell you is different sets of understandings are required for different age groups. And this is a typical tunneling that we do. You will have to tunnel catheters in babies if you want to keep them, because they're very wriggly and they're not going to take care of it as adults would do. In fact, they would do everything to take it out. So if you want to see a tunneling typical video, this is how a tunneling would be done. So please note where your entry point is. This is the cephalad, and we have, this is the notch, this is the neck here, and this is how the needle is being put in. We do this very, very common for forearm surgeries in children, especially infants. Remove the stellate. Now thread the catheter. It is an aerial view if you've noted. Be very mindful about this. Otherwise, the whole catheter can come out, or there could be knots at the lateral end. And now the whole catheter gets its skin cover. But see to it that there are no acute turns, otherwise your infusion pump is going to stay pregnant. In the sense, when you put the elastomeric pump here, it is going to get very difficult for it to deliver the local anesthetic, maybe at 3 ml or 5 ml, whatever you have decided at. If there is a kink here, this is what I'm trying to show you. So let it be kink free. Let the lumen not be jeopardized anywhere. Yeah, so this is how you would set up an infusion. This is how we would put up catheters. How we would put up catheters, take a 2He needle and just be at the lateral cord. Do a hydrodissection and go ahead. Well, now, how about this particular block? It has come into vogue because of ultrasound. Prior, we wouldn't do it because the pleural dome were right inside the neck. But the supraclavicular block is really now rampant in children, a very easy block. And this is how you put the probe and the needle. And now you can see the subclavian artery, and we would see the drug deposition. Really, we do not go at the ulnar pocket. We do not, we just see to it that we are not inside the fascicles. That's all. We do not really bother going all around. We just look, we just take one point and inject at that. That's enough in babies. Interscaling, we do not have many indications, let me tell you, unlike adults. But if there are indications, they're real solid indications, because there would be a sick child with a septic shoulder. Well, this in these cases, truly can circumvent general anesthesia here by simply holding a mask. Just make the child quiet. Give a quick interscaling, calculate the dose well, 3 kilograms, nothing more than 1 ml is required. And if you want to see this video here, look at the heart rate going. The artery is going to tell you, you will not know really where the subclavian perivascular has begun and where the interscalene has ended in this age group. Put 1 ml and you're going to get your block, and the whole surgery can happen only in that. Reflections, which blocks are common? I just told you, the forearm, the hand, and the elbow blocks are common. Which cases would be for catheters? You can add additives, but catheters are for those which are extremely invasive surgeries and the pain is going to linger for a long time, such as maybe radial club hand repairs. This is the only catheter. This is or very, very bad elbow open fractures. Dosages, we know now. Tunneling, we have seen. Coming to lower extremities, let's come to sciatic nerve block and femoral nerve block. Sciatic nerve block, PNS wise, well, we were very, very comfortable with this as well. PNS is lithotomy position, simple. Now let's go to the anatomical landmarks. Greater trochanter, ischial tuberosity. Go right at the junction of it. Otherwise, from there, draw a line towards the popliteal triangle, the apex of the popliteal triangle, and the line drawn from this point. Divide into 3, come to the lower half of it, and anywhere along with it, and give your sciatic block. We do not chase numbers in PNS guided. We stay at say 0.5 or even higher. We can come lower down just to be sure that we are not inside the nerve. But it's not that we don't give the drug if we do not really get twitches at 0.5. 0.5, 0.75, even 1, we do accept, and we give blocks in kids because tissues are supple. Coming to ultrasound, could be dual modality or could be straight ultrasound. So ultrasound has really changed sciatic in a very, very big way. Catheters are very, very common these days for complex surgeries of the thigh. At the ankle. Thigh came in my mind because I was supposed to complete the tourniquet. So this is the sciatic posterior of the body, anterior of the body. This is the biceps femoris. This is the skin and subcutaneous tissue, and here is the sciatic nerve. Here comes the needle, drug dissection, LA deposition, anechoic shadow. Go on the anterior side of the nerve, go to the posterior side of the nerve if you want to. Otherwise, one injection is going to kind of have a good spread. Now, how can you use this for your benefit? This can be a background for your catheter insertions if you require a catheter, if the surgery is that invasive. So this can be an epidural needle, as simple as that. So once you use it with the epidural needle, thread in the catheter. So here the catheter comes out. It all can be observed very well. Go with the catheter inside by 3 or 4 centimeters, and that's all. Even 4 centimeters is not required. Turn the probe, flip it longitudinal. You will see catheter and then the longitudinal needle as such. This is again another sciatic example. This is what I meant when I say that you can see the longitudinal sciatic nerve and then you can see the local anesthetic all around. So these were a couple of examples of sciatic injections and catheters, and this is another example of catheter. Now we are on the posterior of the nerve. Does it really matter? No, it doesn't matter for the success. You can be on the anterior as well as the posterior aspect. It was just for the visual impressions for you that what you would see if you want to put sciatic catheters in children. Do I really bother for the end motor responses if I can see the sciatic nerve, and do I really bank a lot on PNS to begin with? If you are put in congenital anomalies where you're working with arthrogryposis or you're working with say the frozen ankles as such, you are not going to get much movements at the ankle and at the toes anyways with PNS. So PNS was something. The failures, not failures, but the what should I say? The predicaments of of PNS is what pushed actually me at least towards more and more of ultrasound. So let go of the end motor response. If you are very sure of your anatomy, sonoanatomy, and you can see the needle there, even if the PNS stimulation doesn't come concomitantly, give off your blocks. I'm saving time. Having said that, yes, there are certain googlies in congenital anomalies which can flummox you. You will come to see that there are certain muscles which are actually atrophied, and they actually can look like nerves on transverse section and confuse you there. So there are to and fro thoughts, and hence regional anesthesia remains interesting always. So let's come to femoral nerve block. Well, landmarks are the same in adults. Palpate femoral artery to be sure that you're not too close to it. So inguinal ligament, the lateral junction of lateral 1/3 and the medial 2/3. So this is how, and the quadriceps contractions of the patellar dance. Well, if you get knee contractures of this kind, ultrasound would be a good option. Ultrasound is a good option anyways. So this is how you would see. This is the lateral, this is the medial, the anterior, the posterior, the skin subcutaneous tissue. This is the iliopsoas muscle. So this is the fascia iliaca, and this is the fascia lata above it. So, and this is the femoral nerve, femoral artery and femoral vein. You can take up epidural needle and go ahead catheterizing it as well. Go ahead, put a catheter in there. Coming to rectus sheath and tap. So they're very, very easy blocks. So this is the this is how the needle and the probe orientation is. This is the rectus belly, and this is the posterior rectus sheath where the needle has to reach and deposit the drug. Mind you, this is the peritoneum, and this is not even few mm, so be careful. So this is how the drug would be deposited. Now let's come to taps. They're very easy and they're very helpful in laparoscopic surgeries as such, but mind you, as the wall blocks are wall blocks, as the name says, no visceral analgesia here. So let's look at the video here. 1 and 2 and 3 layers. So this is the transversus abdominis, and this is the internal oblique. Get in with the needle and peel away the fascia. Don't do anything to the muscle, because the muscle, if you bloat the muscle, it's going to cause pain. Peel away the plane. Peel away the plane. Open the pain. Yeah, so that is the correct injection. Now let's come to iliohypogastric and ilioinguinal. Confession, not my everyday block, because my surgeons kind of, they don't like their planes to be disturbed. So this is the ilioinguinal, iliohypogastric. Go near it. A couple of blocks. So this is another day-to-day block, a ring block. We use it very often for circumcisions. In fact, in neonates, this is where we've almost circumvented general anesthesia. Warm ambient temperature of the OT, wrapped up in warm, nice cloth, warm dextrose or warm 5% dextrose or warm sugar water, and then let them suckle on it, and then give a good ring block by a very small needle, well calculated dose if you want, by the surgeon, but let the surgeon wait till the block picks up. I've made you imagine this scenario. This is actually not the baby, but calculate the drugs and do all this and let the suckling on the sugar go on, and you can actually circumvent general anesthesia totally. So this is a ring block. Come to penile block. So this is how we palpate. Pull the penis a little lower down. Above here is the pubic symphysis. An area opens up here, goes straight. You're going to get a give of the fascia there, the Buck's fascia, and then 11 o'clock and 1 o'clock. This can be done with ultrasound as well. Local infiltration, a humble local infiltration, can be done even after a hernia surgery and is going to give you enough analgesia in the post-operative. Mind you, will never give you operability. Now let's come to the newer blocks as such. Dr. Edward, do I have time? Do I stop?
No, madam, you go on. We can take 3 minutes.
Sure. Thank you. So, probe position, probe needle, we are approaching QL. Ponder a bit here. This is the posterior of the body. This is the anterior of the body. You see the skin subcutaneous tissue, the external oblique, the internal oblique, the transversus. Now, this is a real small baby and you can see all together. Just turn a bit around if the child is a little older, and then you will see the tip of the transverse process and the vertebral body. QL and then psoas and ESP. These are the three muscles. Take this visual impression, keep this in mind, and let's go ahead. We are going to see the video in different ways. We're going to see different things. So this is called tracing. We trace it. Now, hold on. If anybody gets, while we are working, and if we get flummoxed a bit here and we get confused with the sonoanatomy, let's understand how we can make it even more clearer. Follow the video. Stay with me on the same page. Hold on. Can you see something here? This is the transverse process. Bones are friends in ultrasound. Even if they cast shadows and they limit our vision, they are friends in ultrasound. So this is the tip of the transverse process, and hence has casted a shadow for us to recognize that this is a transverse process. What is this? This is the body of the vertebra. Again, a bone, a friend here. So what has our friend created? A bunny rabbit. Can you see a face? This is the face and this is the ear. Am I calling for imagination? Please be imaginative and be with me. And what is posterior to the transverse process, to the vertebral body? The psoas. Here is the lumbar plexus, and here is the psoas, and here would be the this is the psoas. Here would be the QL, and here would be the erector spinae. Carry on with the video ahead. So the needle is here injecting QL1. Sometimes I wonder, I think we're complicating anesthesia, regional anesthesia a lot. Wait, let me complete. Again, back to me. Transverse process, tip of it, vertebral body. This is the lumbar plexus, this is the psoas, this is the QL, this is the erector spinae. Can't be more clearer than this. And in a baby, you will realize that whether you give it to QL1, whether you give it to QL2, they're one and the same, hardly few apart in a child. Maybe for a pyloroplasty, and the kidney would be kind of, the pylorus would be full with urine. So this, you really don't have to go through all the 4 QLs ever. Well, coming to ESPs, so let me take my way of doing ESP, and I feel more confident here this way. Look at the transverse process. Come to the tip of the transverse process. You want to be retrolaminar? Go at the laterolaminar. In baby, sooner you will realize that it just doesn't matter where you inject because it percolates. Paravertebral, just next, let me just pause and spend some time with paravertebral here. Paravertebral, a real good block, and I always do it in transverse because anatomy is more easy to decipher and tell. See where the transverse process ends and where the rib begins. While giving the block, if you can be very, very clear, but in a small baby, this anatomy is really going to tell a bigger and a better detailed story. So I would rather work in this transverse process. You know where the how the probe is kept, haven't you? I'm missing a good feedback from all of you because I'm not face to face with all of you. So this is the posterior, this is the anterior, this is the transverse process, this is the pleura. And now let us look and understand the entire anatomy as it were here. So what forms the medial border? The medial border is formed by the epidural space. This is the spine and the vertebral column and the central neuroaxis. What forms the floor? The floor is formed by the transverse process and the membrane here. Now the roof. Now what forms the floor? Actually the pleura. So this actually is the paravertebral space, and the needle trajectory is going to be like this. And when you actually inject, the pleura should be displaced down, and you will never see much of a drug deposition in the actual place as such because it is under the shadow of the transverse process. Okay, let's go ahead. This is something that I have kept reserved because this is not a very new block as such, fascia iliaca, but it is of a big benefit for us, especially for those surgeries which have come for plate removals. Plate removals in distal femurs, even in proximal femurs, they help a lot. The only hitch in this block is if you want to keep catheters, take them away from the surgical site, tunnel them away and let them be under tegaderm, and you can ask your surgical colleagues to treat the tegaderm as skin. Let them paint and drape it. So with the probe longitudinal below or above the ligament, the inguinal ligament, you can't tell where it has, what has begun and what has started once it's longitudinal. So this is the dome-shaped muscle is the ileum. I'm going to rewind this a little so that I describe it to my heart's content. So this is the iliopsoas muscle, and this is the fascia, and which has been intersected by the needle. It could be a Tuhi needle if you want to put in catheters. This is a volume block. Around 0.75 ml is per kilogram is always at least required. And what we did was we started injecting dyes to see, and we did go to L4 vertebra, so we were going till psoas, but then we need to put in good volume to reach there, and these blocks are effective. Costoclavicular, well, in children, to be very, very honest, no real big advantage as such, but provided you get just everything in one go. All the cords are not scattered around the artery, they are here in the artery. I mean, being a fan of catheter insertions in the intraclavicle area, I feel the catheters become very superficial in this, but it is a very good block. The only advantage that I can see it is all the cords are together, and they actually, the drug that is given here can percolate above the clavicle. That's all I can think of. Maybe that is the only advantage. Now coming to another block, which is if you are a cleft palate person, I mean, we have a long list of cleft lips and palates. So for cleft palates, this is a block which has really given me a lot of satisfaction, because maybe they both are interrelated. I'll tell you why that satisfaction. Pain scores are better, number one. Number two, the surgical colleagues have come and told me that these children in whom we've given this block ate better. The quantity of feed that they took is far better. And for a palate repair, if that can be a feedback, then yes, the block is really doing good. So let's go to the understanding of this block. Dr. Edward, am I okay? You want me to stop? I can stop.
Please carry on. No problem.
Right. So this is this is where we need to go. Okay. So this is the space actually, and this is the zygoma, and we need to get inside here. This is the lateral bridge of the orbit, and this is the zygoma. So at the junction of it is the insertion point. And what is the destination? The trajectory is behind the zygomatic process, and the injection point is right here. Now, who tells us the injection point? Ultrasound. Now let's go ahead. So this is how it would be. So this is how we mark it. For understanding's sake, this is what is palpated, and this is the mark. That's the zygoma, zygomatic process. In literature does talk of landmark, but I wouldn't dare to do that. And I'll show you the probe position. This is the probe position. The ultrasound has to go beneath the zygoma, as it were. It has to show you that particular fossa, pterygopalatine fossa. Yes, is it very clear? This is what we see. So this is how it would be kept. And once you keep it this way, yeah, now the needle insertion would be from the point that we just So once it starts working, this is how the ultrasound images, sorry. So if that's the lateral and that's the medial, so here would be skin subcutaneous tissue, this side would be the maxilla. This is the maxillary artery. Let me make it very clear. This is the pterygopalatine fossa. And here is the maxillary artery. And the needle comes in out of plane, of course. And this is the whole fossa now, which gets flooded with the local anesthetic. You need very little local anesthetic to give this block, maybe 2 ml or 1 ml. That's all. You don't even go to the calculations of ml per kilogram. Controversies, testos remains a controversy. But however, if we are dealing with something as crucial as a central neuraxial block in a baby, lignocaine adrenaline gives you enough adrenaline to work, and on a test dose, adrenaline is a good test dose in a dose of 5 microgram per kilogram, provided it is given in this dose. Nothing is lost by giving it. And if I get it, I mean, in my practice at least, I have got an increase in heart rate due to lignocaine adrenaline. So yes, there is a controversy, as the name suggests. Compartment syndromes, there is a controversy, but don't give them a dead limb. Give them a limb which is sensory blocked to some extent and not motor blocked at all. So sensory block, comfortable, light sensory block, comfortable patient, eating, sleeping, no grumpiness at all. With a given infusion, with a given post-op regimen, the child is fine. And after that, sometimes the child is grumpy, irritable, not looking happy at all, refuses feeds, don't do anything, call the surgeons to look into the plastic. It can be the first telltale sign of any ischemia setting in. That's how the controversy would be. You know, awake and asleep, no more a controversy. Consent, present, no more a controversy. Tell the parents, tell the child. Children are very smart. They listen to everything. So may as well address them. So these are the common controversies that pediatric regional anesthesia still faces. Coming to last management as such, this is the AORA chart. So last management, we don't have any luxuries here. No luxuries in babies and even children, because they're anesthetized or sedated. So we don't get any people talking to us in a bizarre way. No tingling, oral numbness, no tinnitus. We straight either get convulsions or we get cardiac arrhythmias. So the answer for convulsions is, of course, secure the airway if it is already not. Ideally, it always is. Or mask is at least being held. So secure the airway, control the convulsions by midazolam. See to it that first is airway. But I'll tell you one practical tip. When the child starts convulsing, take care of the IV first. Hold the IV hand and then go ahead resuscitating. So 100% oxygen. First, stop the injection. 100% oxygen. Secure the airway. Stop the convulsions by a muscle relaxant or thiopentone or even propofol, or worse, muscle relaxant, a quick dose of scoline also. Secure the airway, control. We'll come to the decision of whether to do surgery or no a little later. Now coming to cardiovascular collapse, all kind of bizarre arrhythmias would be thrown. So please do not practice regional anesthesia unless we do have intralipid in place. Please prevent it before it starts by calculating the dosage as well, by injecting in aliquots. Do not rush in the drug at all ever. By using maybe test doses, yes, but a common factor is give injections in aliquots. Be watchful of the monitor. Please position children well before you start. That's another thing. Otherwise, it could be a hypoxic bradycardia, and you might think that it is last. So not everything that happens is last. So this chart is telling you all the treatment that is required in children, the doses. Pediatric 1.5 to 2 ml per kilogram, but diagnose last with discretion. Yes, you can give intralipid at the first suspicion because there is no disadvantage of giving intralipid. But if you are missing a flexed neck, or if you are missing a apneic child due to excessive or just quick bolus of propofol to make the child quieter because the child has just moved because of your needle prick, or if you have missed a laryngospasm which has happened due to a needle prick in a lighter plane of anesthesia and going to hypoxia, for a last, then I guess we are missing a big thing. So just don't get focused on one particular thing. As a pediatric regional anesthesiologist, you need to be a pediatric anesthesiologist first to understand pediatric, the whole holistic scenario as such. And if you've put in catheters, please mind you, you're married to the catheter, you and your team, till the catheter comes out. So I know this, my thoughts are jumping, but I just want to pour in as much as I can. So we have many options. We have, master few basic blocks, because we have a plethora of blocks, and then go to the most COVID or the most new ones. Then choose your block case by case. There is no ideal block for one given block, one given case. I mean, different cases need different approaches. Please tailor make it and keep learning newer things. With this, I am going to take a full advantage of informing you about the Pediatric Regional Anesthesia Workshop in AURA, which is going to happen very next Sunday. So anybody wants to know anything more, you're most welcome. We can spend the whole day together dwelling into this subject. So thank you very much. Thank you. There's a good video to play, but I'll stop it here because I guess I've consumed too much of time.
I extensively covered the pediatric regional anesthesia. Thank you very much. Over to you, sir.
Thank you so much, ma'am. It was like watching a Sunday movie. You have gotten all of us to a wonderful sono-anatomy, sono-neuroanatomy. It was like viewing the nerves inside, from inside. It was wonderful.
Vinothini, I was wondering, I mean, I was very, I was concerned of looking at the participants, and I was thinking whether people have logged out for their Sunday lunch. I'm not too sure.
No, ma'am, we do have many people watching on YouTube live, and this will also be recorded.
No, I'm just telling you my thoughts, because I just thought that I was dragging the whole lecture a bit too much.
No, it was wonderful.
Let me be very honest to you. This is what I thought.
It was wonderful.
Because Nandini was very crisp with hers. She was finished bang on time. And here I am going on.
Pediatric regional is such a vast topic.
Yeah, and you had covered everything. Covered everything starting from caudal till fascia iliaca, and even the pterygopalatine fossa block also. So
head to toe.
Yes, ma'am. It was wonderful. We all know that regional anesthesia in pediatrics is not same as in adults, because from the way it is always in sedated or on a sleep child, and the anatomy is quite different. The physiology is different. The pharmacology also, the uptake of the drugs, everything is different. And the ultrasound definitely proves better. And you had covered most of the topics also. The important, the controversial topics also had been covered, ma'am, regarding the test dose also. Just one small doubt. Do we see the T-wave amplitude? Do you have any insights on that, ma'am? T-wave amplitude?
That's the most specific. But whatever I mean, theory says it's most specific.
Yeah,
whatever I have seen is tachycardia.
Yeah, so
immediate tachycardia.
Yeah.
Not many times, twice I have seen immediate tachycardia.
Okay. So I wanted to ask that only. Is it clinically possible for us to evaluate, like we are in that side and giving to see the T-wave amplitude if it's risen, or it is very difficult. Like, but theoretically, that is what is.
Yes.
Fine. And any test dose recommended for caudal? Do you give a small aliquot in caudal and watch for the response, the heart rate changes, and then go ahead with the full dose? Or if
it's a very practical question you've asked. Let me just explain what we do every day. We take lignocaine adrenaline in a dose of 5 milligram per kilogram, and we take bupivacaine or ropivacaine or levo, whatever, in a dose of 2 or 2.5 milligram per kilogram. Since we are adding both drugs, we reduce the doses of both. But lignocaine adrenaline 5 milligram per kilogram essentially gives us far more than 5 microgram per kilogram of adrenaline as such in it. The commercially available 2% lignocaine adrenaline already gifts us that. Okay, so all you need to do is calculate both the dosages and give it. So you already have your test dose inside your syringe, and give it in aliquots. That's all. You're not losing anything by practicing this. However, there are two schools of thoughts here. Some people really do not use lignocaine adrenaline at all, and And that is fair too, because it's not too specific. But if I'm getting an added advantage of a quicker block, because as I told you, pediatric surgeons don't scrub for a long time. And it's very small an area for a baby. They just paint and start working. So even with adrenaline, the block takes a little longer time than as compared to the briskness with which they'll take an incision. But still.
And any thoughts on tunneling the catheter if you're going to place a caudal epidural catheter?
We don't use caudal catheters unless it's a neonate. So previously we used to tunnel a lot, but in this NICU that I work in, we do tunnel, not that we don't, but they take real good care. So 2 good tegaderms and the catheter and then a gauze piece and a good tegaderm is serving our purpose. So we have kind of we don't make it a point to tunnel each and every case. In fact, there are if there is a case we would really go to tunnel is the spica cases, the hip cases where we have kept catheters and they find it difficult to reach the catheters and pull them out from the posterior aspect, from the back. So we get them out.
Any places where you have preferred the epidural lumbar epidural over caudal for the reason of infection? Anything of that sort?
No,
or
not
with the diaper
really.
on, you can still have the caudal catheter in place.
See, once they become 2-3 months, we really go to lumbar. We don't go to caudal portal anymore for that. So that thought hasn't really struck us a lot because we've moved on to more site specificity. If at all I have preferred caudal over lumbar, maybe in a case of, say, uretary cream plant, the bladder is more of sacral innervation, but the surgical incision and working is, of course, comes from the lower thoracic and the lumbar, more so. So maybe that is the time, although the primary work is in the sacral, I've gone to lumbar and, seen to, I mean, with a hope that it's going to get flooded anyway.
So this you had been like the flooding of the local anesthetic, you had emphasized so many times. So that is a point that is to be noted in pediatric regional anesthesia. You need not go into multi-site injections or any block to take up because the tissues are so flimsy and there's lots of loose tissues in between for the drug to spread on to the entire neurovascular bundle.
Wouldn't have agreed with you more. There's no requirement for multiple passes of the needle at all. That increases the injury.
The risk of, that increases the risk of injury. And always it is loss of resistance with saline than with air, is it?
See, there are people who use saline, there are people who use air, but we use saline for obvious reasons. It's more physiological. We do not have air embolisms. I mean, theoretically, no air embolisms, no patchy blocks. The only advantage of air is you will never miss air for anything else. You will never mistake air for a drug. Normal saline, you might mistake it for a drug. Another practical issue with normal saline is normal saline once you inject is going to come out as well. If you have seen how to put it, you can mistake it for saline or you can mistake it for CSF gushing out. So you can get a bit confused there. So I feel if we can train our minds to perceive the change in resistance rather than the loss of resistance, and whether air or saline, use it to the minimum, that would be better.
Yeah. This point also I wanted to ask, that was my next question. The loss of resistance is always not that very distinct, especially in smaller children. It is only always, most of the times it is just change in resistance. If we, that is what I have observed. I just wanted your insights on that. Many times it's not loss of resistance. It is most of the times, especially in smaller children, change of resistance, where even if you're going to use air, you don't distinctly get that the air does come back.
Yes, actually that's a very astute observation. Vinothini, you think like that. A child who was not walked, hasn't had her The baby doesn't have a ligamentum flavum, which is now gotten some pressure on it, you see. And once they walk and start running around, the ligamentum flavum gives a good loss of resistance. But till then, it is like any other supple tissue.
Nice thought process, ma'am. I didn't think in this perspective. Nice thought process.
And you know how it occurs to you. You go to CP children who've never walked, and you will not get a very, very distinct loss of resistance. You would better than an infant, of course, but it won't be as good as a equal aged person who's walking a lot.
Yes, ma'am. And there was a question from the viewers regarding the gauge of the size of the epidural needle that you use. It is 19 gauge, I believe. If it's a
yes, it's 19, but it's not a very it's not a very friendly catheter. However.
That too with a 10 ml lower syringe in that. I feel that syringe needs modification.
Yeah.
And another question.
But there are 20 gauge syringe needles also. They're better. There is Payank, B Brown. They all have their B Brown catheters slightly stiffer. Yes, we have a plethora of equipments now. Yeah. Please tell me.
There was one question, ma'am, regarding like the video that you had shown about the Nora in the ward. The question is, you have told about Nora epidural catheter that stayed for 48 hours, I guess. His return is 48 days.
14 days.
48 days. Okay, 14 days, ma'am. 1-4.
Yeah, 1-4 days.
Okay, he has written it as 48. Okay, he's heard it as 48, I guess.
So did I write that
right?
That's an error on my part.
Okay, fine.
That's an error on my part.
Okay, fine. And continuous nerve block in children, repeating the dose and what interval, and how many days can we have the pediatric catheter in place?
In very small babies, nothing more than 48 hours. There is a logic behind that. Surgery increases the levels of alpha-1 glycoproteins. So there is a cushion here. So the free drug is less. After 48 hours, these dosages, these levels increase. So bank on those 48 hours. Of course, if the surgery is that invasive and pain continues, don't pull out, taper the dosage and see. And then you give an epidural holiday for a couple of hours. And of course, getting other drugs to play at that time for sure, such as paracetamol and NSAIDs if there are no other contraindications, or patches of opioids, even do anything to see to it that the pain subsides. But more or less in 48 hours, surgical pain does decrease is what we have seen. So for 48 hours is a good thing. But please remember, don't give a numb extremity to a child. They are equally disturbed by that.
There's another question from Dr. Rajesh. Before using sonography, am I supposed to sign particular form medico-legally in view of law in SDT?
Yes, you will have to follow all the PCPNDT rules and regulations. Nobody is exempted from there. But it is not as big a pain as we think it is. Just maintain a register, that's all. And you can allot this work to the OT technicians or somebody, and they do it for you. We do not have that big an issue. I mean, whenever we do a block, the register is kept inside, or the book is kept inside the, we have a bag as such. It is kept inside or on the trolley, and they come and take a sign. So we write the patient, registration number, which block, and we write our sign and the date.
Okay. And Dr. Rajesh Shah has commented, I am doing location of epidural space by attaching micro drip set to the epidural needle. And I don't know what.
Yes, I understand this logic. It is a known method. But I'm not too sure why micro set. It could be a macro set as well. Micro set might pose a little more of a resistance. Tell me your practical experience, doctor.
Dr. Rajesh Shah.
Because I would rather go to a macro, normal set, in other words. I wouldn't go to micro, because micro is going to take resistance. So you might, in a small baby, you might go beyond the ligamentum. I mean, dura as it were. But what he's saying is described in literature. It's a known method. I agree.
Yeah, you had also talked about the compartment syndrome. That was another controversy. Like there, you have to avoid motor blockade and go ahead for a diluted local anesthetic.
Yes, give them a sensory
blockade alone. Yeah,
Yes.
or if at all motor blockade is necessary, you have to look in for the telltale signs of irritability and other things.
But let the surgical team be in your team. They have to trust your blocks enough. And for that, you'll have to take some opportunity and show them that this separation indeed is possible. And sometimes you will, you just have to be very closely knit to them, and they should know you and you should know them very well.
Thank you, ma'am. Thank you for the wonderful lecture. Thank you so much. And thank you, Nandini, ma'am, and Vrushali, ma'am, for making this Sunday.
Thank you. Thank you.
Happy learning
last
day.
question.
Learned so much from
Sarva, that is our last question to Vrushali Pandey, madam.
Yes.
Madam, how will you give regional anesthesia under sedation or under GA? Because initially you said it is economy. Regional anesthesia is more economic.
Yeah. What I mean by economical is two ways. First is, I'll tell you one practical thing. You know, there is one surgeon of mine, and we work together in a very HEP 7-star hospital. Okay, not that economic matters to them, but I'm just sharing this with you. And we started work, and I started going there because I was requested to go for that for those special pediatric cases. So the pediatric the routine anesthesiologist called me and said that you have not booked an NICU bed for post-op observation after bilateral hernia for neonate. When we would do it with a mask, sevoflurane, and a good caudal, and the neonate is going to be in his cradle at home by, say, late evening after feeds. So this is how it is. That does not mean that this is the norm. We could intubate, we could put an LMA, but I'm just sharing you our practical experience. That is one way of looking at it. Another way of looking at it is when you put in catheters, say for thoracotomies. Now, of course, we have a lot of VATs going on. For thoracotomies or CDHs, unless there is a surgical indication for ventilation, they breathe very well. They get extubated. Even if we go and put them on ventilation, they do not need sedation to that extent. And of course, a continuous fentanyl infusion, which otherwise one would have given and found weaning a wee bit more difficult. So we are kind of giving them a lesser, the period of recovery is far more kinder and better and shorter when we give a region.
Thank you, madam. I am able to understand. It is a perioperative reduction of the cost.
Yes, yes.
Thank you, madam. Thank you, Vrushali madam and Nandini madam, taking your time on the Sunday to present us in the platform. Thank you, one and all. I also thank the sponsor Akrula and our host A1 Logics and the partner Anaesthesia TV. Thank you, viewers. We will meet the next week with a more interesting topic. Thank you, one and all. Thank you, sir.
Thank you, ma'am.
Thank you. Thank you. Nice meeting you, Nandini.
Yeah, same
Thank
here.
you, ma'am. Thank you.
Thanks, Vinothini.
Thank you,
Thank you, Dr. Edward. Thank you.